Good morning, everyone. There's so much excitement in the poster area that we're still going to have to get started here. So welcome to our 6th annual research day. It's going to be absolutely fabulous. Today we are going to bring our vision of university hospitals alive to advance the science of health so that we can practice the art of compassion. And I have to say, in the last half hour, it's been very inspiring to see incredible posters covering our comprehensive nature of science here, both basic, translational, clinical, and health services research. And it's great to see everything from medical students to fellows to junior faculty. We have an outstanding program today. I really, before we begin, I want to thank our UH Research and Education Institute team of Yi Fritz, Nicole Bollinger, and Abigail Zona, who've done an amazing job trying to put this together. I want to thank all of the poster participants, all of the judges, and most of all, I want to introduce now, because we have to get going, Stephanie Teal, who is the chair of OBGYN and the OBGYN-in-chief of the University Hospitals Health System, who is a health services and health implementation science researcher as well, and is going to be the overall leader of today's activities from a master of ceremony standpoint. So, Stephanie, it's all yours.
Thank you, Dan. Thank you for that. Welcome, everyone. Great group, and I know we also have a large group online as well. So as Dr. Simon was saying, over the past several months, the UH Research and Education team have been working really hard to ensure we have an amazing program for you today. We have speakers across the full spectrum of research, from basic translational to clinical and health services. And we also are delighted to feature two keynote speakers, Dr. Fabio Caminelli and Dr. Atul Chopra, who will be speaking to you later this morning. Also, thank you to everyone who submitted applications for the abstract competition. We received over 60 this year, and winners will be announced at 11:20 a.m. If you missed the poster session this morning, please stop by during the coffee break or at noon. Just a couple of housekeeping issues. For the audience watching the event online, please use the chat option for questions. They'll come to Nicole and she'll text them over to me. And we're going to answer as many questions as possible, but we're also kind of doing a blitz program. So if you have any questions that aren't answered, please feel free to reach out directly to any of our speakers or email to uhreinstitute@uhhospitals.org. For our speakers, as you know, kind of a tight schedule, so E will be waving at you if you go a little bit over. And with that, we'll go ahead and start the program by introducing Dr. Sarah Ranas. Dr. Ranas is an academic pediatrician and health services researcher dedicated to improving systems of care for low-income families and their children. She's the director of the Center for Child Health Policy at UH Rainbow Babies and Children's, and today she's going to share with us her research study on socioecological profiles of children with asthma in Cuyahoga County. Dr. Ranas.
Thank you very much for that. Thank you, guys. Eager to get going. Thank you for that introduction and the opportunity to share our work. As a health services researcher, my team and I work in the T3 to T4 end of the translational spectrum, so implementing evidence into practice and disseminating into community for population health benefit. The data that I'm going to share with you today is preliminary data from the BREATHE study, which is generously funded by the CTSC of Northern Ohio and as a research program project under Module E. This funding mechanism is really exciting for us because it aims to reduce health disparities in chronic illness through the use of technology, and explicitly calls for the integration of community perspective throughout the research process. To that end, I want to make sure to acknowledge all the amazing partners and collaborators in this work from across the CTSC partner institutions, the American Lung Association, 2 of our large local school districts, CMSD and Cleveland Heights University Heights, as well as, importantly, parents of students with asthma. We have no disclosures. So childhood asthma is among the most common chronic conditions of childhood with substantial public health burden, really a heterogeneous collection of airway diseases involving airflow limitations and airway inflammation, impacts more than 6 million children in the United States, of whom more than half will have an attack in any given year, resulting in nearly 250,000 emergency department visits or higher levels of care, and even deaths. As a pediatric primary care physician, this is top of mind for me because it's top of mind for our families and our community. So this figure shows recent data regarding prevalence of childhood asthma among 3 to 17-year-olds. And you can see in Northeast Ohio, which is the red bar, more than double the rates of asthma in children in the state of Ohio and the US overall. And we see excess burden of asthma among children who identify as Black or Hispanic and children who are publicly insured. Chronic absenteeism is a really important marker of asthma control in children. Defined as missing more than 10% of eligible days, we know from the medical literature that children with asthma who are chronically absent have greater symptom burden overall, more often live in households, neighborhoods, and attend schools with increased levels of indoor air pollutants, and which in turn sets them up for greater risk of exacerbation that keeps them out of school. We know from the educational literature that children who are not in school, in addition to missing their academic opportunities, are missing really crucial social and emotional developmental opportunities that happen in the classroom settings. That said, historically, it's been very challenging for investigators to put together a holistic picture of this problem, in part because most of the literature that I just referenced is reliant on self-report data. So the overarching goal of the BREATHE study was to identify and test community-endorsed strategies to optimize school attendance by this population, overcoming the limitations of prior work by, in the first aim, quantitating patterns in administrative data. In the second, generating that holistic understanding from semi-structured interview with parents, educators, and healthcare providers. And in the third aim, generate some pilot data what a future state might look like within a technology-informed intervention. So I'm sharing today data from the first aim. Our research question was to define which socio-ecological factors are associated with chronic school absenteeism among Medicaid-insured children in our community, so that highest risk group. We expected, consistent with the literature, that chronic absenteeism would be greater among children with asthma as compared to those without, and that we would see excess absenteeism among students with asthma associated with their neighborhood of residence and their school of record. To test these hypotheses, we linked individual records from 2 large data sources. The first is the child data system housed at MSES in the Center of Poverty. This data draws from 35 administrative databases. It goes back 35 plus years, and importantly includes social services, housing, and school records. And then we leveraged UH Medicaid claims for children ages 6 to 12 who had at least one Medicaid-insured encounter with university hospitals during our study period. We defined our children as asthma as having an encounter with an ICD-10 code of J45, so that asthma group plus prescription evidence for a beta agonist or inhaled corticosteroids, the medication used to treat asthma, and our comparison population had no such evidence. We used the Anderson and Day framework to help us identify which variables out of these large data sets we were going to focus on, with our key outcome being absenteeism, shown here on the right in red. So of the nearly 65,000 children who met inclusion criteria in our Medicaid claim set, we were able to successfully match nearly 2 and 3 into the child data system. In the end, we had just over 25,000 children with school records available, of whom nearly 5,000 had evidence for asthma. So our first hypothesis was that children with asthma would have poorer attendance than those without. So in this figure, the green arrow shows the desired direction. You want fewer children to miss school or more children to have adequate attendance, defined as less than 10% of days missed. In blue, we see Medicaid-insured children with asthma with adequate attendance. Gold are our UH patients without asthma, and then the red X's are the state-level estimates overall at the same time. This figure was incredibly striking to us in that while we expected some disparities and we replicated those disparities between children with and without asthma, we observed that attendance has really substantially declined over time, with fewer than half of our kids having adequate attendance in the post-pandemic years. When we looked at our data by school building, we saw high levels of heterogeneity. To illustrate, I'm going to highlight 2 school buildings of similar structure in similar locations within the county and similar levels of representation in our data set. We observed different attendance patterns between children with and without asthma, but incredibly high levels of absenteeism overall. And importantly, academic year over academic year, we did not observe consistent patterns by building. So narrowing in on students with asthma, of that 5,000 in our data set, the majority, as expected, were male, identified as Black and non-Hispanic. We saw them appear in 14 of the school districts in the county, with Cleveland Metropolitan School District accounting for more than half. Because of those high rates of chronic absenteeism, we looked at a few different ways to operationalize the outcome measure for the further analyses. And in the end, we landed on this definition where we saw chronic absenteeism in 2 or more of the 4 academic years. And just about a quarter of our students met that criteria. In terms of our demographic fixed factors, we found in unadjusted analyses that children with asthma in our data set who are persistently chronically absent were more often born to mothers of lower levels of educational attainment, were more often themselves premature. And while those who were persistently chronically absent were about 8 months on average older at first entry into our data set, we found no significant differences by sex, race, or ethnicity. In terms of potentially modifiable factors, in unadjusted analyses, we found that children who were persistently chronically absent more often had tobacco exposure documented, more often resided in neighborhoods with lower health and education opportunity, more often had a concurrent diagnosis of ADHD, anxiety, or depression, or mental behavioral health diagnosis, and had lower asthma medication ratios. So fewer achieved the quality metric of 50%, meaning that for every rescue inhaler filled, they also had a controller inhaler filled. Unfortunately, while we have information about which school building students are in, we don't have information about the level of support for asthma at those sites. That's a data element we're working on right now and hope to integrate in the future. Nevertheless, when we put this all together in multivariable logistic regression, accounting for demographics, we found that all else being equal, at a household level, tobacco exposure as a marker for poor home indoor air quality was associated with greater odds of chronic absenteeism. Residence in neighborhoods with higher health and education opportunities was protective. And in terms of children's health care needs, those with mental or behavioral health comorbidities had a 34% greater odds of chronic absenteeism. And while not statistically significant in the model, there's a suggestion that higher asthma medication ratios are also protective. When we conducted sensitivity analysis using generalized estimating equations to account for clustering by neighborhood and school, we found similar findings. We have a lot of limitations. So our absenteeism data doesn't tell us the reason for absence, so it could be asthma related or not. We don't have the information, as I mentioned, regarding school supports at those sites. Our preventive care, so our well child data, doesn't account for visits outside of the UH health system, so the kids could have been getting preventive care elsewhere. And our sample is blind to children who had no contact with university hospitals or who are enrolled in charter, parochial, or home schools who are not providing data to the state. That said, we've generated some really important takeaways to inform both practice and future research. For me, again, wearing my clinician hat, Medicaid insured children obtaining care at UH have incredibly high rates of chronic absenteeism, something that every clinician who works with them should know, should be asking about school attendance, absenteeism, and the reasons for that absenteeism. For children with asthma, the influences on attendance aren't limited to asthma alone, and in particular, clinicians should hone in on children who have both asthma and mental behavioral health diagnoses because they're at particularly high risk. And we're seeing some opportunities as a health system that we could intervene to reduce that risk, including increasing the proportion of children who are achieving an adequate asthma medication ratio, screening for and treating those mental and behavioral health conditions, facilitating connections to care, and supporting schools. So our next steps, we are actually next month integrating qualitative data that I have not talked about in this presentation as part of a participatory group model building activity facilitated by the Center for Community Health Integration. We'll be using that to identify action strategies to be prioritized, and that's going to inform the back half of the project where we actually get to pilot it. So thank you very much for the opportunity, and I'm happy to take any questions.
Dr. Simon.
Sarah, that was really wonderful. I have a question. You know, some of your maps look strikingly similar to Sanjay Rajagopalan's work, looking at heart failure, heart attack, coronary calcium, and using a lot of very interesting geospatial modeling, 2.5 micron, ozone, tree coverage, walkability. Have you incorporated any of these measures into determining whether it's specific to neighborhoods of ozone and 2.5 micron exposure?
So while we've not included air quality data into these analyses, the proxy that we used that I blew past really fast was a measure called the Childhood Opportunity Index. This is developed out of the Ohio State University, pulling together multiple data sources to rate each census tract in terms of health and education opportunity. I'm going to forget the other two components that go into the overall measure. So we use the health and education sub-index for that, and we use the metro normed scores. So looking at the Cleveland metropolitan statistical area, how far off one direction or the other were these neighborhoods to median. It looks even worse when you look at compared to national norms.
Thank you. All right, go ahead. We'll do one more question.
Great job. Piggyback on Dan's question with Sanjay's data. So have you looked at the same zip code census tract to look at, because there are individuals living there that are on Medicaid and not Medicaid who might have asthma, obviously, to see what the factors for absenteeism then could be as you control then for that factor?
We've not looked at students without, we've not looked at patients who did not have Medicaid claims. We're relying on the Medicaid claim set. But I think that's another important limitation to this data is we're seeing sort of the tip of the iceberg and a very narrowed down specific population that doesn't represent the full breadth of asthma experience for all students.
Great, thank you.
Thank you.
Sarah. So, it is now my pleasure to introduce our first keynote speaker, Dr. Fabio Cominelli. Dr. Cominelli has over 30 years of research expertise in the area of experimental inflammatory bowel disease and intestinal cytokines. His contributions to groundbreaking research on gastrointestinal conditions, including Crohn's disease and ulcerative colitis, have helped alleviate pain and complications for tens of millions of people worldwide living with these disorders. His group was the first to report that blocking a single cytokine producing a robust anti-inflammatory effect in animal models of colitis and an imbalance between intestinal pro and anti-inflammatory cytokines represents a pathogenic mechanism of autoinflammatory diseases, including inflammatory bowel diseases. These and other studies have formed the foundation for critical clinical trials using anti-cytokine therapy as well as administration of anti-inflammatory cytokines in patients with autoinflammatory diseases. In 2023, Dr. Cominelli was honored as a distinguished university professor, an honorific title that acknowledges the contributions of full-time tenured faculty with exceptional records of research, scholarship, teaching, and service by the Case Western Reserve University. Please welcome Dr. Fabio Cominelli.
Thank you. Thank you, Dan and Stephanie, for the organizer of this, for giving me the opportunity to present some of our data. Before I start, I want to remember our beloved chairman, Bob Salata, who unfortunately passed recently. I still remember the days when I started here as a new division chief with Dan and Bob meeting and building the Department of Medicine that we have today. So today I want to talk to you a little bit about translational research going on in my group, in my lab, with specific reference to anti-cytokine therapy in IBD and basically how this has really made a very difference in the treatment of this patient and developed some new drug FDA approved by the FDA for this condition. So this is my view of the pathogenesis of IBD. IBD includes Crohn's disease and ulcerative colitis, affects almost 3 million individuals in the United States, several million in Europe. And a cartoon like this that I put together many years ago tells you that we don't really know the cause of the disease. This is remembers me when, in the 80s when we were talking about peptic ulcer disease, aggressive factor, acid production, and then Barry Marshall, who actually won the Nobel Prize for work in my division at UVA, discovered that a simple infection, Helicobacter pylori, caused a disease of such important like peptic ulcer disease. In IBD, there is a genetic susceptibility. There are over 300 genes that have been associated with IBD now, but in general, it's a polygenic disease, probably one of the most successful examples of genetic studies in complex diseases, with several genes identified, such as NOT2, which was the first one, TL1A, IL-23 receptor. And the importance of genetic study has been the understanding of pathways that can be targeted for therapy. In fact, today we have, Stelara is basically blocking this pathway, and very soon anti-TL1A therapy you will see in my talk. The environment is very important in this disease. There are many factors that have been associated with the environment. Of course, the gut microbiome, diet, smoking is the most important risk factor for IBD. Good in ulcerative colitis, a bad in Crohn's disease. We don't still understand why. There is overall an epithelial cell dysfunction. The mucosa at the surface of our body clearly plays a major role in this disease. Now, the interaction of this factor leads to activation of the immune system, and one of the areas will be activation of inflammatory cells and activation of what we call cytokine gene expression. One of my contributions, as Stephanie said, was in 1990 to publish one of the first papers where blockade of a single cytokine was effective in treating this condition. And this was an important concept because in those days, the dogma was that you block IL-1, TNF takes over, you block TNF, IL-6 take over, you block IL-6, IL-23 takes over. So the idea that blocking one single cytokine, like the TNF story has taught us, and you can have such a major impact on the disease, was a novel concept. So in my career, over 30 years ago, we started to concentrate on cytokines that we call innate cytokines. So cytokines that not only are involved with the differentiation of some subtype of lymphocyte, but cytokines that have much more, a more pleiotropic effect, what we call a master cytokine effect, really to modify the inflammatory response in this situation. And this is a very interesting reflection about my career, the timeline of cytokine biology in IBD. When you get older like me, you start to develop timelines, you look back. And if you think about the interleukin-1 was cloned in 1984, I was fortunate enough to work with Charles Dinarello, who cloned and discovered the first interleukin-1. And from a series of studies, looking at IL-1, TNF, interleukin-33, now we have several drugs that are approved by the FDA for the treatment of inflammatory bowel disease. And I consider myself very fortunate being at the bench cloning the cytokines and then many years later to see drugs that are approved for the treatment of this condition. It doesn't happen every day, as you know. In terms of our approach, we have been using models, animal model, mouse model in particular, that are relevant to the pathogenesis of this condition. And there are many models. There are hundreds of models to study inflammatory bowel disease. The most common is the DSS colitis model, where you feed mice for a week with the chemical substance, and the mice develop some acute colitis. But this model really don't have anything to do with the human condition. So we try to develop model that is much more relevant in terms of pathogenesis and also, what did I do? Pathogenesis. I guess I touched something here. Okay. Models are much more relevant in terms of the ability to predict response. One is called the SAMP mouse model. The other one is a model called the TNF delta-3 mouse model. And I don't have a lot of time to explain you all the details, but these are chronic models. One spontaneous, where with multiple genes involved. The second one driven by an overexpression of TNF. We developed this model many years ago. So the SAMP, why the SAMP is so interesting, so important, because the mice have a pathology, localization of disease, the terminal ileum. As you know, Crohn's disease is also called terminal ileitis. They have these lesion, skip areas, areas affected, alternating with areas that are unaffected, compared to a normal mouse, our control, you see, where there is no disease, all the villi are intact. Obviously, this area cobalt lesion that we see when we open a specimen of a patient with Crohn's disease after surgery are where the action is going on in terms of inflammation, thickening of the muscularis, fibrosis, stricture, which are all event-generating symptoms in patients. The TNF delta 3 is simpler in one way, the TNF delta 3 mouse model, because it's driven by overexpression of TNF by a genetic mutation in the ARE region of the TNF mouse. We published this and developed with our collaborator George Collias many years ago. It's a very popular model. Hundreds of labs are using this. And actually, with our center, we are able to provide these mice to investigators in the United States and all over the world. And the disease is a little bit different. It's continuous inflammation, but these mice develop two major pathologies, Crohn's-like ileitis and arthritis. As you know, the two diseases where anti-TNF has a major effect in patients. So the SAMP mouse spontaneous is also very important because mice develop stricture and fibrosis. This one is the hottest area in IBD research because obviously these complications of fibrosis and stricture are only treatable by surgery. There is no today medical therapy that will work in this situation. And also a discovery that was amazing to us that these mice spontaneously develop what we call perianal disease, so inflammation in the perianal area with fistula that penetrate into the rectum, inflamed rectum. These are one of the major complications in patients with IBD. Probably 30% of patients with Crohn's develop this complication. And to think that a spontaneous model developed this similarity with the human condition, the ability to study this condition for which there is very limited therapy is amazing. So the first cytokine that I want to talk to you about is the TL1A DR3 system. We started to work on this probably 20 years ago. And the reason we focus on this pathway is that TL1A DR3 as a co-stimulatory molecule for lymphocytes regulates or is involved in the regulation of all the major lymphocytes and cell subsets that are involved in inflammation in general and in mucosal inflammation in particular, Th1, Th2, Th17, the new subset Th9, for which we have a paper almost accepted in gastroenterology now, innate lymphoid cells, which are the new kids on the block in terms of important cells in the mucosal immune system. So looking at a master cytokine that can regulate mucosal inflammation IBD, this was a very good candidate. These other cartoons show you the different diseases where TL1A has been implicated, so not only IBD, but asthma, rheumatoid arthritis, other diseases, and all the different cell types that are involved. So again, another timeline, sorry, but this is a timeline that shows you what it takes to develop a drug after a discovery. So we publish and we discover, so this was discovering DR3 by Human Genomic Sciences, TL1A, DR3 was, the receptor was described before. We published the first paper discovering the role of TL1A, DR3 in inflammatory bowel disease. And then, today we have clinical trial, phase 2 clinical trial. 20 years later, we have a drug that is approaching the FDA approval. And talking to the company now developing this, the first drug will be available in 2028. So it takes basically 25 years from time of the discovery to the development. Now, unfortunately, I'm not going to be a billionaire because I did not put my effort. So there are some investigators that pursue this field, and now the company that developed one antibody, Prometheus, has been sold to Merck for $12 billion. So some people are going to be billionaires. I'm not going to be a billionaire, but I'm happy because my approach to science, as you see, I don't have disclosure because I believe that academicians should not be involved with drug development. The two careers, in my opinion, don't go together. And I care about improving the quality of life of patients with IBD, and I leave to others to be billionaires by drug development. So I'm happy with my life and my discovery, and not being a billionaire. Anyway, besides this little transgression, the role of TL1A in IBD, so they just show you a list of studies that show all, I don't want to go into details, but TL1A is increased in lesions for patients with IBD, the receptor expressed in lymphocytes, so all the background in humans that provide the rationale for going after this. And I just want to show you these slides from our initial discovery, because I think this was a major discovery because at that time TL1A was considered an endothelial factor involved with vascular biology. We discovered that it was expressed in lesion of patients with IBD, that the receptor was expressed on lymphocyte. We discovered also the many cell type were able to produce this protein, and therefore providing a strong rationale for additional study. We went back to our animal models, and we show also the expression in, this is a paper published in PNAS, we show the expression of the ligand in our models and the appropriate expression of the receptor. So the approach that we use, and I can go fast here, was to develop genetic deletion of the ligand, the receptor in our mice, and to study blockade by antibody blockade to study eventually what will happen in patients. So these are our experimental procedures that we do routinely. So we cross our mice with the knockout models, then we generated the genetically mutated mice, and then we study all our fancy assays in terms of evaluation of colitis, endoscopy, cytokine measure, and so on. And this obviously is a large amount of data. I just want to show you this one, that when we cross our SAM mice DR3, when we cross our SAM mice with the deletion of the signaling pathway of the receptor, we saw a tremendous amelioration of disease, almost complete suppression of disease compared to the normal mice, intact mice that develop this progressive chronic ileitis up to 40, 60 weeks. You can see here the difference histologically and the difference macroscopically. So this was very good indication that this signaling pathway is very important in this model. Several cytokines were suppressed, interferon gamma, TNF, IL-13, IL-17A, all cytokines that play a major role in mucosal inflammation. And one aspect that is very important of this molecule, this is probably the hottest area in gastroenterology. Every meeting there are tons of talk, everybody talks about this, all the investor wants to invest on TL1A. I got one call a week from investors, they want to know about it. This is a good investment to invest in this molecule. There are probably 5 or 6 pharmaceutical companies now developing antibody for this. But one important aspect is the role in fibrosis, because there's been some important indication that this pathway is important in activating myofibroblast, fibroblasts, therefore developing those stricture stenosis that I told you is one of major complications. And in our mice, when we look at our SAMP DR3 mice cross with the DR3, we saw a tremendous amelioration. So this is a normal mouse, this is a regular mouse, this is the knockout. You can see the difference in tremendous amelioration, not only inflammation, but the collagen deposition, and so on. So suggesting that this pathway could be very important in regulating fibrosis. Now, the question always remains, when you block a cytokine like this, is the effect of fibrosis because you suppress inflammation or you suppress inflammatory fibrosis genes? But we also did some analysis on the effect on fibrosis genes, and you see that, for example, alpha SMA, collagen 1, MMP3, there is tremendous downregulation of this inflammatory. So there is the hope that this could be a treatment once approved that increase or decrease the incidence of fibrosis in this. Then, in order to prove that this was not something specific to our SAMP mice, we turned to the other model. And in the other model, I just wanted to concentrate on this. We saw a very similar effect where the deletion of DR3 generate also a significant amelioration of disease. And also shown here in terms of histology, MPO activity, which is biochemical index of inflammation, and suppression of the pro-inflammatory cytokines that I described before. One very interesting thing that we observed is that when we cross our TNF with the ligand now, TL1A, we saw a much lesser effect in older mice. We saw really no effect of deleting. So deleting the receptor, very strong. Deleting the ligand, not so strong effect, but only early in disease, but not later. And when we do the same experiment with our SAMP mice, actually we saw no effect. So very intriguing results where now the drugs that are being developed are against TL1A, and it's not surprising that there is some effect there. So the effect is positive, but is not certainly 100% resolution. So obviously our model represents probably a subgroup of the 70% patients that don't respond, they have lesser effect with TL1A. And we then did the neutralization experiment with antibody, and we saw a very remarkable similarities or identical results with the gene knockout, where blocking TL1A in the TNF early on was effective, non-effective in later disease, and non-effective in SAMP. So one area that I hope to pursue in the next 5 years in my new grant, if it's funded, will be to understand why blocking the receptor is more effective than blocking the ligand. More recently, we have a paper now almost accepted, as I mentioned, in gastroenterology. We turned to a new subset, which is a Th9 cells and interleukin-9, which is another candidate cytokine for potential treatment of IBD. And when we use our SAMP-DR3 mice, we saw a significant suppression of interleukin-9, suggesting that this is another important pathway that is regulated by DR3, TL1A DR3, also showing here that basically there is, in our mice, lacking the receptor, there is downregulation of this pathway. And when we block interleukin-9 in our mice, also we have positive effect. So to conclude this part of my talk, our results suggest a differential role of TL1A and DR3 in early and late stages of disease. DR3 is a pro-inflammatory role both in early and late phase of Crohn's disease like ileitis. TL1A displays different roles early and later phase of disease. Obviously, the one explanation of our hypothesis is that there are more ligands than TL1A to activate the DR3 signal, which has been described for other cytokines such as OX40, for example, or LIGHT, other members of the TNF family have more than one receptor. So the conclusion is that DR3 signal is a major regulator. A blocking DR3 may represent a novel therapeutic modality. Now, as I mentioned, there are companies developing anti-TL1A antibody. The prediction is that this drug are going to be approved soon. We are going to be working on DR3 specifically to prove that blocking DR3 is more efficacious. So these are the future perspective of our work. So we are working on two non-ligand for DR3 in addition to TL1A. One is called progranulin, and one is E-selectin. We have already some good data that these are overexpressed also in our mouse model. So the idea will be that if you block TL1A, but also these other ligands, you are able to block completely DR3. And also, we are after very difficult task, the discovery of new ligands that have not been identified before that could explain these results. These are very talented people that work with us to develop this project for this part. And these are the two studies published today. Again, remember, the satisfaction of physician scientists to make a discovery in 2003 and then see drugs that are effective in patients. It doesn't happen very often, I can guarantee you. So the first study was published in patients with ulcerative colitis with what we call the Pfizer antibody that now has been sold to another company. And the second one just came out a couple of weeks ago in the New England Journal of Medicine in terms of the Prometheus antibody in ulcerative colitis. But also there are studies showing that this approach is also effective in Crohn's patients. Now, a few last minutes, I want to tell you about another story, which is the story of IL-1. IL-1 has been obviously the passion of my life since I started to work with this in 1985. And interestingly, for interleukin-1, there has not been any clinical trials blocking IL-1 in patients with IBD. As you know, there is a drug, anakinra, who is approved for the treatment of rheumatoid arthritis and other conditions. But for sometimes difficult reason to explain, no company has gone after interleukin-1 in a systematic way for inflammatory bowel disease. And one of the reasons is what happened in the pharmaceutical industry. Nobody wanted to compete with anti-TNF, and it was difficult to push this issue. I believe that IL-1 has a very important role in IBD, and our approach has been to go after, interleukin-1 alpha, because there are two isoforms of interleukin-1, one alpha and beta. IL-1 beta is the secreted form. IL-1 alpha is functional as an alarming, and basically is secreted, is released by epithelial cells and other cells upon necrosis, injury, functional with the function of what has been defined as an alarming. And our hypothesis is that this function in the intestinal epithelium could be very important in terms of pro-inflammatory effect. So there's been a lot of study related to interleukin-1. This is an advice for younger people. Please, I tell all my people in the lab, read the literature, because if you're young, you go to a study section and review a grant, you make statements. So my last grant, one of the criticisms was that IL-1 alpha, IL-1 beta, we didn't show that IL-1 alpha was increased in patients with IBD. So we published this, other people in 1990. Maybe the reviewers were not born yet, and therefore they don't know the literature. But please make sure that you know the history of some of the molecules. But anyway, a lot of work has shown that IL-1 is very important. And again, as I mentioned before, the alarming function is intriguing for us in terms of being able to release by cell through necrosis, pyropoptosis other expressed, that could then create a pro-inflammatory effect to this molecule. So what we did, we designed, as usual, we obtained a very good mouse monoclonal antibody against interleukin-1 alpha, and we decide to basically do a neutralization study like we do for many of our molecules that we test. We use dexamethasone as a control. Dexamethasone works very well. So there are two things that work very well in some mice, making this model predictive of therapy: dexamethasone, corticosteroid treatment, and anti-TNF. Those are the gold standard of treatment in patients with Crohn's disease. We designed our study, and basically we assess the severity of ileitis with our usual system. We measure cytokines, and also we measure effect on the microbiome, and so on. So we prove again the IL-1 alpha and beta are increased in our sample mice. So on the top, you see our sample mice called Bestol lesion, control mouse. You can see the tremendous upregulation of both IL-1 alpha and IL-1 beta at the protein level and the transcript level in terms of upregulation of the protein, which is one of the things that you always want to see when you try to block a cytokine. And when we do our study, we saw a pretty remarkable effect in terms of anti-IL-1 alpha treatment comparable to dexamethasone in terms of statistical difference between these two groups. And you can see the histology: inflamed control mouse, one treated with dexamethasone and one treated with IL-1 alpha, the restoration of the normal mucosa with the villi, intestinal villi, the decrease in thickening of the muscularis across the stricture, and so on. So very good effect. Suppression of cytokines with increase of IL-18 that now is considered a anti-inflammatory cytokine. So very interesting that blocking IL-1 increased one of the family members, interleukin-18. And to conclude this part of the study, in our model, we're able to show that IL-1 alpha may be a major pro-inflammatory cytokine. This may represent a novel therapeutic modality. At this point, we have been lucky to complete the planning phase of a clinical trial using a human natural antibody against IL-1 alpha, collaboration with this company, XBiotech. We actually, it's a very interesting story that before COVID, we obtained funding for this study through the DoD, so we got a fundable score. And then what happened, the company sold the antibody to a big, large pharmaceutical company. And what the large pharmaceutical company, without mentioning name, did, put this away, and there's not being way to test this. But because the original company still reserved the rights to develop new antibody, we have now new antibody that we can study in this area. So I think I'm doing okay with time. And so now I want to just try to conclude with one of the area also that is very important to me for the next 5 years of my career, maybe the last 5 years of my career, and the concept of anti-cytokine, advanced combination therapy compared to anti-cytokine monotherapy. So it's very interesting. If you look at the drugs used in patients with IBD, all the drugs work only in 50% of patients. We've never been able to understand why, but no drugs show an effect that is more, in the best scenario, 50%. When we look back all the study we had done in our mice, when we use anti-IL-1 alpha, we saw a 31% effect. When we look anti-SC2, which is a blocker of interleukin-33, another cytokine that Teresa Pizarro in our group here at Case is studying very extensively, and anti-TNF 39%. So if you look at the primary response of patients with Crohn's disease with biological therapy, the response is 30%. Because, patients respond 50%, and then after 1 year, another 50% lose response. So this is unbelievable, remarkable in terms of how this mouse model resemble the primary response in patients. So one of the things that, again, if we get additional funding in the future, we're able to do, will be to explore the concept of advanced combination therapy, which is combine, obviously, molecule that has been done effective in rheumatology, for example, and try to explore different combinations of cytokines. Of course, some clinicians that we work with are very excited about this because by doing this advanced combination therapy in mouse model, in a relevant mouse model, you're going to be able to then develop good clinical trials in that area for patients. The idea is that by doing advanced combination therapy, you can break the therapeutic ceiling of 50%, maybe go to 70, 80% to really have a remarkable effect. These are the acknowledgement for the other part of the work, especially some of my collaborators on the right side, a series of very talented people on the right side. And most people are gone now. We have very new postdoc and junior faculty are very talented. Okay? So I think I can finish at this time. I think I finished on time. And thank you very much. Happy to take any questions.
Thank you very much. Maybe I'll get the question
Sure.
started with one of the last things you mentioned, which was advanced combination therapy. And I wondered if you could just elaborate a little bit on, what you have in mind.
Yeah. So the advanced combination therapy to break the therapeutic ceiling, there are basically two approaches. One is to use drug in a different category. So you can use a biological therapy with a probiotic. You can use a biological therapy with a dietary intervention. So that's one approach. And obviously, the idea there is to hit the disease from two different pathways that have a synergistic effect. The other one is to combination therapy within the same class, for example, biologic, where you can use anti-TNF and Stelara, for example, and anti-23. And see, again, if by using drugs in the same category, you have a synergistic effect. Obviously, that's the approach that we want to use because that still gives you the option of using another category and not exhaust all the medical therapy at once.
Questions from the audience? Okay, I get to ask my second question then. Fantastic. You talked quite a bit about IL-1 alpha, and I just wondered if you could tell us, is there any more we should know about IL-1 beta?
Yeah. IL-1 beta is the classical IL-1 members. There are drugs that have been developed. Canakinumab is an antibody against IL-1 beta. There's been a famous big trial done with that. Anakinra is IL-1 receptor antagonist. But the concern about blocking IL-1 beta is that IL-1 beta has very significant homeostatic effect, regulation of epithelial cell integrity in the gut, barrier function. Therefore, the idea is that blocking IL-1 beta will be compensated by the deleterious effect of blocking the homeostatic effect. Therefore, we concentrate on IL-1 alpha for that reason. And actually, when we block IL-1 beta in our mouse, we see a much lesser effect on the inflammation, suggesting again the IL-1 beta, similar, for example, to IL-17. IL-17 in IBD, when it's been blocked in IBD, there are deleterious effects because of the homeostatic regulatory effect.
Dr. Simon.
So Fabio, you've been focusing on terminal ileitis or Crohn's disease. What is the biology differences between that and ulcerative colitis?
Yeah, so basically the ulcerative colitis affect only the colon, is continuous inflammation and superficial inflammation. Crohn's disease affects any part of the gastrointestinal tract. Interestingly, all drugs that we use work in both disease or they don't work in both disease. So that has been an area where we've been trying to understand the difference between the disease, but unfortunately, like in many other conditions, there are fundamental questions we don't know. Why Crohn's affect the terminal ileum and ulcerative colitis only the colon? But In terms of anti-inflammatory therapy, the biology is very similar and the drug works in both conditions. I hope one day we will understand more and being able to have specific treatment for one or the other disease. Yes,
Hi, Fabio. Great talk.
thank you.
Quick question. So we know these anti-inflammatory effects are very effective, in the ileum and the colon. Can you tell us about some of the systemic effects, and then what do you think about the combination therapies that are being proposed? Will they only augment those sort of deleterious effects?
Yeah, so
systemically?
when we look at this anti-cytokine therapy, there is always the other side of the story. So these cytokines also have homeostatic effect. We produce cytokines in a normal situation if you don't have a chronic disease. So we always have to consider the possible side effects, right? So biological therapy, lymphoma, cancer, infection. So obviously, you gotta be careful when you push the combination therapy, where you push the side effects. So for example, blocking DLL3 might have very significant immunosuppression that it won't make it a reliable source. So the question is excellent, and we always have to keep in mind, for example, now there's a company working with anti-DLL3, they're doing all the phase 1 trials, primate study, because toxicity is always a major concern. I guess similar to what you see in your oncology patients, right? So that's why I asked. Yeah, no, it's a very good question. I am very cautious when, to push immunosuppression. No, immunosuppression and autoimmunity are the price we pay for blocking, for biological therapy.
Great. Thank you.
Oh, thank you very much.
Now it's my great pleasure to introduce our next speaker, Dr. Mehdi Shishabor. Dr. Shishabor is the president of UH Harrington Heart and Vascular Institute and the Angela and James Hambrick Chair in Innovation. Dr. Shishabor is continuing our theme today of outstanding researchers who are also outstanding clinicians. He was recognized by University Hospitals in 2020 as a distinguished physician for his commitment to patient care. But turning back to his science, Dr. Shishabor is an internationally recognized expert in minimally invasive approaches to reconstruction of lower extremity arteries to treat critical limb ischemia and prevent amputation. He's the principal investigator of the PROMISE II U.S. pivotal clinical trial, which enrolled 105 no-option patients across U.S. centers. The results were actually published last year in the New England Journal of Medicine. He received the 2024 Top 10 Clinical Research Achievement Award from the Clinical Research Forum to recognize these profound contributions to advancing clinical research. And today, he'll share with us his award-winning research study, PROMISE II.
Thank you.
All right.
Thank you so much, Dr. Thiel, and thank you, Dr. Simon, and the organizers for this kind invitation. It's really an honor to obviously be here. And I'm going to take you to a little bit of a journey today around the work that we have done for over a decade in regards to a condition that affects a significant portion of the patients with diabetes and chronic kidney disease. The condition that we treat, that I treat, is called peripheral artery disease. Many of you may have heard about it. It's typically asymptomatic for majority of the patients. If it becomes symptomatic, it usually presents itself as a lifestyle limiting claudication. These are patients that when they walk, they get pain in their calf, and when they rest, the pain goes away. So relatively kind of a benign. In the field of cardiac, we say this is like a stable angina, somebody that has a stable blockages and disease in their arteries. When it gets to the more severe form, we call it critical limb ischemia. These are patients that are at risk of losing their limb and getting a major amputation. These are normally or usually are below knee or above knee amputation, which has significant clinical and psychological implication. Now, unfortunately, this disease has not had a lot of advances, unlike some of the other diseases you've been hearing today. It has really struggled. The morbidity and mortality from this disease is enormous, even more than combined breast and urologic and colon cancer from a standpoint of the mortality. 50% mortality within 5 years with CLTI in this population. And fundamentally, the main issue in this condition is lack of perfusion. We don't get enough blood to the tissue, we can't heal the wounds, and patients end up with an amputation. Unfortunately, despite the fact that it has significant morbidity and mortality, there has been little advances in this field. Indeed, in the last 20 years, we have not had any FDA-approved pharmacologic or mechanical interventions for this condition. The only thing we use is really wires and balloon, what we call balloon angioplasty, which is a rudimentary device that we use in the field of interventional cardiology and vascular surgery. So no advances in over 20 years, significant morbidity and mortality. Now, I apologize for putting this picture, and Yi was like, are you sure you want to show this picture? I said, well, these are the patients I see. So while I'm sorry, I hope I don't upset anyone, but the reality is that honestly, behind each of these pictures, there is a face and significant psychological, emotional, and lifestyle implication for these patients. I'm proud to say that all of these patients were able to save their limb prior to even what I'm going to discuss with you with our research today. So there's been a lot of technical advances, even though pharmaceutical and technological advances have been limited. Technological advances have allowed us to do a lot. And I wanted to share with you a case that we did here at UH a few years ago. This was an 86-year-old female who came to us with a number of comorbidities and actually had a prior below knee amputation a few years ago, 4 years back. She has type 2 diabetes. And she now came to us with this kind of a picture on the good leg. So one leg is already gone, and she has this leg. And she also, in addition to having necrosis of her toes and having this, what we call dependent rubor, which indicates there is significant ischemia, she had this lesion in her Achilles tendon. So I didn't go showing you all the work that we did, but we are able to treat even patients like this with the current technologies. What the problem is that this condition, the prevalence of CLTI is on the rise. There are more and more patients that we see, and unfortunately, despite all the technical advances and our commitment in saving these limbs, like the patient I just showed you, about 20 to 40% of the patients are still considered no-option patients, which means that we cannot even offer them what I just showed you with a previous patient. And these patients end up with a below knee or above knee amputation because we have no opportunity to do a bypass for them because there are no targets in the foot, and endovascular options with wires and balloon angioplasty is not successful because the arteries are so calcified and so occluded that we cannot get down to the feet and get to the tissue to improve perfusion. This cohort of patients, we call them the no-option patients. And like I said, majority of them, if not all of them, end up with a major amputation in the United States. And as I've indicated here, over 150,000 amputations happening in the United States. So about 10 years ago, a group of us got together and we said, well, is there a way to try to utilize other veins and arteries in the leg and be able to supply oxygenated blood to these tissues that are at risk and save the limb of these patients? So think of it as like a kind of a traffic jam, and you're able to jump on the other highway and get through the traffic and then get back to where you need to go. So with that kind of a mindset, a group of us got together and we said, you know what, let's do an early feasibility study. Now, this was during the time that the FDA really was not open to early feasibility studies in the United States. But because there was so much limitation here in the United States in regards to CLTI treatment, as I showed you, very few tools in our armamentarium to be able to treat these patients, they allowed us to do this in the United States as an early feasibility study. We were allowed to do 32 patients at 7 sites. UH was one of those 7 in the United States. These were patients that we call no option. Again, they had no option of bypass surgically, and they had no option of endovascularly. And there was a committee that was designed to make sure that that was the fact. So you couldn't just say, oh, there's no option, I'm going to do this procedure. You had to submit the angiograms and all the data. There was a multidisciplinary independent committee that reviewed all the angiogram and all the data, and then they approved whether the patient was no option. And the idea was that, can we assess this concept? Is this concept even feasible? Can we even do these procedures? And if we can't do them, what is the safety of this? How should we select the patients? How do we assess the wounds? How do we follow up these patients? And so on and so forth, in the hope that if this was positive, if there was a reasonable signal, we would proceed to an IDE trial. So this was a group of us. It was a multidisciplinary team of vascular surgeons and cardiologists and interventional radiologists really working together to do this study. And what we showed from the early feasibility study at that time, the 6 months, this is later on obviously, but at that time when the 6 months data came out, we showed that we were able to have a freedom from amputation of 77%. And this was pretty shocking to us because remember, these were patients with no option at risk of major amputation. And we were saying that 2/3 of the time, we can at least save their limb by 6 months. And honestly, the side effects were not extensive. There was pain and there was some edema, but there were things that were manageable in this group of patients. And we felt that this was something that we could, take to the next step. So through a series of meetings with the FDA, we decided to design the IDE trial to get this device and this technology approved through the FDA. I was fortunate enough to be the co-PI, national co-PI, with my partner, Dr. Dan Clare, who is a vascular surgeon from Vanderbilt. We had 105 patients that we had sample sized at 20 sites. And the uniqueness of this study was that the population that we studied had never been studied before. Because as you can imagine, when you're trying to study patients, you always want to minimize type 2 error, right? You want to study a very clean sample of patients that have at least going to have good outcomes and are not going to hurt what you're trying to test. In this population, we went after the sickest of the sick. So all of these patients had Rutherford 5 and 6, meaning that they either had tissue loss or gangrene. These were not the claudicants that I showed you in the first pictures. This was not the group of patients with just rest pain. These were people that really had an ulcer and they were at risk of amputation. The second thing is that we allowed dialysis, which have always been excluded from all pharmaceutical and device trials because these patients don't do well historically with any kind of a trial or intervention. The second challenge was that, and we allowed, obviously, this Rutherford 6 is even sicker patients. And as I said earlier, these were no option CLTI. So all the images were sent to a committee that decided that there were no option for these patients. The other challenge was that can we do this as a placebo control? And this was a lot of going back and forth with the FDA in regards to could we have a control arm where we offer them nothing, and basically amputation. And it was honestly felt that one, we would have a very hard time enrolling patients because by this time, we were already doing this procedure off the shelf, even here at UH. I've been doing these procedures for over 10 years off the shelf using devices, putting devices together in some of the patients to try to do this procedure and get blood flow to their feet. So we felt that it would be very difficult to enroll patients. We felt it would be a little bit unethical because there was no other therapy that was reasonable because, again, they were defined as no option patient. So the FDA decided to give us the performance goal kind of a comparison to do this study and have a single arm study rather than a randomized placebo control in this population. And these were the other secondary endpoints, obviously wound healing, Rutherford class, and so on, and pain classification. So the way this procedure works basically is that in our patient with diabetes and chronic kidney disease, they have significant, this is the kneecap right here, they have significant below knee tibial disease. These tibials are 100% blocked, there is significant calcification, and you have to get the blood flow all the way to the toes. As you know, many of the arterial ulcers happen in the distal foot. And if you get the blood flow just to the ankle, it's not gonna be enough. So the idea was that can we divert the blood from the proximal portion of these tibial arteries into the venous system? And it turns out that we have a lot of veins in our calf, many, and we could just use one of those veins and enter the vein, put covered stents through the vein, and then divert the blood from the artery into the vein, getting oxygenated blood in a reverse flow format to the feet so that we can heal the tissue. And these are some of the devices, proprietary devices that we use to get this procedure done. These were all the sites that participated. We were one of the sites, obviously, as part of PROMISE 2. And again, no option patients, inclusion of the dialysis patients, and Rutherford 6, which is the latest stage of PAD. These are people with gangrene that need at least a minor amputation, meaning that they're going to lose something. We call them Rutherford 6. So the sickest kind of cohort of patient, this is an example of a desert foot. This is the kind of a foot that was enrolled in the study because there is no target here to bypass, and there was no way to fix this endovascularly. 80% of the patients had already had an attempt at endovascular revascularization in this population. This was the cohort of patients. As I said, many of them have diabetes, almost 80% of them. We were proud of the diversity of the patients that were included in this trial, including African Americans and Latinos in this population. And as I said, about 35% of the patients, a third of the patients had Rutherford 6, which was the end stage of this condition. The technical success from the study, which is a pretty new kind of a procedure, and I'll show you a picture, was 99%. So very appealing and surprising that we could be successful in 99% of the cases. This was the primary endpoint against the performance goal, and we met the criteria for performance goal. So the study was positive from a standpoint of the performance goal. But honestly, I think to me, I think this is what the story is all about. The fact is that we had a 66% amputation-free survival. So amputation-free survival is the freedom from amputation and survival. It's an endpoint that the FDA is very stuck with, even though we never thought that this technology will prolong life per se, but they forced us to use that kind of an endpoint. A lot of these patients, as I said, they die. So we had a number of deaths, and this was during the COVID era. So we lost about 4 or 5 patients because of COVID. In any case, we had 66% amputation-free survival, a 76% limb salvage rate, and an 87% survival rate in this study. This was a subgroup analysis. As you can see, aside from dialysis, almost everybody did better with the DVA, deep venous arterization, in this cohort. And the conclusion of the trial was that obviously the trial met its primary endpoint. It was effective and safe. It was 99% technically successful, at least at these 20 sites, and 76% of the patients had limb salvage at 6 months. I'm proud to say that we are now just submitted the 2-year follow-up, actually, of this trial for publication, and we have a 74% limb salvage survival or freedom from amputation at 2 years. So there's sustainability beyond 6 months with this technology and this kind of intervention. And just to share with you one example quickly, I think I'm going over time, I'm sorry. This was one of the patients that we enrolled here at UH as part of the PROMISE 2. She was a 73-year-old female with a Rutherford 5-6. You can see the ulcers here in her foot. She had multiple comorbidity, which is the kind of population that we get in these studies. And as you can see here from the angiograms of the ankle and the foot, there's really no arteries here in the foot. You see here, this is the right below the knee, this is the anterior tibial. This is what we call the tibioperoneal trunk. There's one artery here that ends here in the mid-calf, and then there is nothing really in the foot here for bypass or for a stent. So this was a patient that we bring in. So what's unique about this trial is that we have to get access in these patients in the bottom of the foot. And that's something we've never done in our field. So this is there's some unique nuances about this procedure that we had to learn, and we are able to get access. This was done many years ago, and we're able to get access. We are able to bring our wires up the vein, down the artery, have them meet each other and connect. And then through this process, we can create this kind of a blood flow to the foot. So now we are able to bring the blood here from the artery, divert it into the vein. This is the vein now on the bottom, and we get this kind of a perfusion down to the foot. This is usually what happens after the procedure. The next day, there's a lot of ischemia because you're stealing the blood from the foot, from the native arteries, and take it to these venules, which are not yet been arterialized. So we see this kind of a worsening of the symptoms, pain for about 3 to 4 weeks. But then this is the happy moment when we are able to heal the foot. And this is a patient actually that we've done now for a few years, and she continues to walk. She has not had any recurrence of the wounds, and she's doing fantastic. Thank you so much. This was published in New England, and we got FDA approval last year, as Dr. Thiel mentioned. This was the first device to get FDA approval for CLTI ever. There's not been another device or pharmaceutical drug that has ever been approved for this condition. Thank you.
Thank you so much, Mehdi. That was fantastic. Can you tell me about the uptake and adoption of this technique nationally, internationally at this point?
Yeah, so we have done now 2 trials, one in Asia that has also shown similar outcome and is now been approved in Asia. And also in UK, we did a similar trial that also showed similar limb salvage rate. So it's also been approved in Europe, is available. As I said, is FDA approved here in the United States. It's currently has a NTAP, through CMS. So it's commercially available across the United States. We have it here commercially. We're also pursuing additional research in this area. So we are involved with the PROMISE 3, which is trying to understand more about the patient selection and other features of this technology as we offer them to our patients.
So we actually do have a couple of minutes if you wanted to give us a hint about PROMISE 3. I think we'd love to hear about it.
So yes, so there are a couple of areas that we are pursuing as it relates to this technology. One is that, can this technology serve as an adjunctive therapy for even lower risk patients? Because remember, up to now, we have been studying this for no option patients, people that have no option. And a lot of us feel that this is really end stage. And these patients not only have significant vascular disease, but also have a lot of comorbidities that any device or any operation in them is not going to have the best outcome. And given how safe this technology has been so far, based on our experience here in the United States and abroad, as I mentioned, is that should we be offering this kind of technology to people that maybe have a compromised blood flow, but not this extreme, that they are not no option, but they are in a stage of compromise, meaning that they are not the lowest risk people that we can just bypass or easily fix and get significant blood flow for them, but they are in the middle between no option and that cohort. So we are in communication with FDA and with the various organizations to see if we can put a trial together to see if we can move the needle a little bit more downstream for patients that are in the middle between no option and lower risk.
Yes.
Thank you, Dr. Shishabur, for the fantastic presentation. My name is Omid Haji Asani from Department of Surgery. My question goes back to the field that I work in, that's cancer. One thing that we know about tumors is the environment they create because of the low perfusion, and that environment neutralizes many macrophages, a lot of immune suppression, and then help the growth of the tumor. Is it possible to apply a similar approach with the perfusion to tumors in different locations in the body and deliver drugs better and have a better perfusion in the system?
Yeah, it's actually a great point. Honestly, and again, I'm not an expert in cancer, but I think from a standpoint of perfusion, I think this has opened eyes for us in a sense that we can utilize other blood vessels to get oxygenated blood or perfusion to areas that there is a lack of perfusion. And we are actually also doing some research right now in the arm for patients that have ischemic hand. So there is some communication and discussion in regards to selective patients that have ischemic hand. These are also diabetic patients and maybe a scleroderma, some other conditions. So I would say that there may be other utility of this technology for other areas where you want to have more blood flow to be able to get drugs or therapies to that segment.
Dan?
Yeah, I just wanted to make a comment that it's really nice to be here and know that we can lead in research in the U.S. and nationally and internationally. And last year, Mehdi Shishabur and Amru Siraj, I nominated them for something called the Clinical Research Forum Award, which is that every dean is allowed to nominate 4 people. So there are about 400 nominated in the U.S. UH nominated 2. The dean accepted our nominations. And Mehdi Shishabur and Amru Siraj were awarded top 10 in the United States. So that's very exciting and should be very inspiring to see that you can come up with this simple concept. If the road is blocked, can I take another road? Here, the road happened to be a vein. So congratulations, Mehdi.
Thank you. And I want to throw it right back at you, Dan. Thank you for all of your support with research. We know that what makes us unique. We know that research is hope. You always say this. And it's really what brings us to work, because if it's not for the research and the science, and the impact that we can make on these patients is really sometimes hard to come to work in this era of healthcare. So thank you.
And I think Dr. Technos?
Yes, Mehdi, obviously fantastic work. Congratulations. You know, the other hat I wear is a microvascular surgeon, and reversing flow in a vein is fraught with disaster because you have valves, and the valves block flow when it goes antegrade. So how do you overcome that in the foot? I know you talk about, you know, stripping the valves out of the main veins, but then in the foot, you know, how do you overcome it? Because you can't strip the valves all the way down to the distal venules. And then the second question is the pain that you're experiencing just, you know, the alternative veins learning how to return blood to the foot? Because what's the venous outflow then if you're using the veins for arterialization?
Great questions, Ted, and thank you. Actually, you hit on a nail even in another aspect, which let me address first, which is the microcirculation. So we have been saying for years that, you know, PAD and CLTI and this condition is a macrovascular and a microvascular disease. We have balloons and stents for the macrovascular, but we have had significant limitation in microvascular. As you know, there's been a number of biologics that have been studied, and I see Dr. Stamler also there. There's been a number of biologic studies of various form to try to improve microperfusion to the foot. Unfortunately, we have not been successful. Interestingly enough, I think this has been a very unique way to improve microperfusion in a reverse way through the venules into the foot. Now, you raised a good question. So we can address, and you're right, the bigger veins, you know, in the calf, and even some of the veins in the foot, not the venules, but in the foot. We do go in there, and we do have valvotomy devices, and we damage and destroy those bigger valves in the calf and in the foot. But because of there's so many tributaries, and we don't really, and we think because of the pressure, those valves, those venules, those valves become dysfunctional because the arterial pressure is so much higher when it gets to that level of the capillary bed. And at that level, that it just opens up, there's so much dilation that the blood is able to get through. And that's why we think that it takes a little bit of time. It takes about 3 to 6 weeks for that maturation to happen, because for that dilation to happen, to allow the oxygenated blood and the arterial blood to get through the venules, the small veins, and to get to the capillary bed takes time. And we think that what's dealing with those valves, those smaller valves that we cannot get to, is that pressure, that arterialized pressure that's coming that they're not used to, which allows the dilatation and makes the valve basically dysfunctional. There's no more coaptation and allows the blood to go through. And when we take a picture, it's interesting, you know, and I didn't get into it in this presentation, but when we take pictures of these patients 3 months, 6 months later, it's amazing. The arterialization of the foot is just incredible. We never see that when we work on the arterial side. So there's a lot of recruitment, if you will, of the capillary bed and a lot of arterialization of the venules. Regarding the veins and, you know, the fact that we use one of them and so on and so forth, as you know, each of the tibial arteries have 2 veins that run by them. So we have 6 tibial veins. We have the small saphenous vein, we have the greater saphenous vein, we have the lesser saphenous vein. So actually one of the main concerns we had with this condition was that would there be a lot of edema in the foot? And we haven't really seen that. The pain is real, and we think the pain has to do with that maturation, but also from steel, because, you know, we are really competing with the native blood flow by creating this system, and we take some time for that maturation to happen, and during that time, we typically treat this patient with narcotics while they get that maturation, and the pain goes away.
Thank you so much.
Thank you.
Dr. Shishabor. That was fantastic. Thank you. All right, our next speaker is presenting actually from Abu Dhabi. So I think that we are all set. Is that right? Okay, wonderful. Dr. Amrou Siraj is the principal investigator of SELECT and SELECT-2 trials. The SELECT-2 research study was conducted across 31 comprehensive stroke centers and tertiary hospitals in the US, Canada, Europe, Australia, and New Zealand, with UH as the coordinating center. In 2024, Dr. Siraj also received the 2024 Top Clinical Research Achievement Award by the Clinical Research Forum, as Dr. Simon pointed out. This makes UH the only hospital system to have 2 honorees acknowledged in 2024 by a national consortium for the 10 most significant clinical advancements impacting the health and wellness of humanity. So today, Dr. Siraj will be talking about recent developments in large core thrombectomy, the SELECT-2 trial, and sub-analyses.
Thank you so much for the kind intro. I think I should say good morning, everybody. It's evening here, but thank you, Dr. Simon, for having me, and thank you, Ms. Fritz, for accommodating. Pleasure to join you from here. I'm here to present at the World Stroke Organization conference. So that's how I happen to be in Abu Dhabi. We'll share what we have done in the SELECT-2 trial, and we'll share few future frontiers on what can be coming. So I'll start with the aforementioned SELECT-2 trial, which was a randomized phase 3 trial that, as was mentioned, conducted in North America, Europe, Australia, and New Zealand. And we used covariate adaptive randomization to balance the baseline characteristics. You don't want sicker patients, those who are older with larger strokes, to be in one group versus the other. So that was the basis. This is a diagram of how patients were enrolled. Everybody got the baseline CAT scan, and those patients all have large vessel occlusion in the internal carotid artery or in the middle cerebral artery first segment, the MCA. M1, all of them got a CAT scan. The difference here and the basis of the trial is we are enrolling patients with large strokes, those who were not being treated in the past under the concept of too much tissue damage to treat, less likely to benefit, and too much risk of reperfusing the tissue with high risk of hemorrhagic transformation. So the risk-benefit ratio is not in favor of the patients, or that was the thought process. As you see on the CAT scan and the principle of looking at imaging, that's what we teach the residents and the fellows, that you look for asymmetry. You look to the left, you look to the right. Hopefully the resolution is good for you to see that the left, there is a large hypodensity in the left MCA. We didn't do just simple imaging with the CTA, but we also did advanced imaging with perfusion imaging. You see here the software that we use, the Rapid software, which takes the perfusion and calculate the volume of the infarcted tissue and the tissue at risk. And the pink area here is the infarcted tissue, and you see 92 cc's. This is a large stroke. Anything more than 70 cc's was considered a large stroke prior to SELECT-2 and a couple of large core trials. And those patients were not treated. And we did MRI in some cases, and you see the pink area is the infarct. So those patients prior to these to SELECT-2 and other large core trials were not being treated, not part of the guidelines. Guidelines were calling for randomization. And what we did, actually, we did this pretty methodologically. We started with SELECT, which was a phase 2 non-randomized trials, and we found signal of benefit with reasonable safety profile. We proceeded based on it with SELECT-2. Those were the sites, mostly North America, but about 1/3 of the sites were in Europe and Australia and New Zealand. This is the enrollment chart, and putting this bring a lot of good memories. This is where we enrolled. We enrolled about over 3 years, and the plan was to enroll 560 patients. But after 3 years, the DSMB asked us to stop for reaching efficacy, and then it became non-ethical to randomize patients. But what I want to bring your attention to, if you remember, this is around when the trial was just starting. This is when COVID hit. And there was a lot of challenging on how to enroll, and IRBs asking the investigators to close the trial, and hard to get patients and their families or their families to consent. And what you see that we actually moved pretty good. That was because of a lot of work from myself and the co-investigators instituting remote consenting, increasing the sites numbers, and working with IRBs that at the end of the day, this is in the best interest of the patient. So we moved very well, and we were stopped around 3 years. And pride myself that with the fact that this is not the usual that you see where the principal investigator resides. Most of the patients are enrolled. Actually, we have 2/3 of the sites enrolling 10 patients or more. Almost everybody contributed. Of course, I'm going to give UH as probes. You see here, I came to UH around August of 21, and the trial was stopped in September of 22. So within less than a year, we enrolled 21 patients. And this is one of the strengths of our system, having a lot of hospitals to feed and having people who can identify and enroll patients. So we screened about 1,000 patients to enroll 352 patients. 174 went to medical management, 178 went to thrombectomy, 2 crossovers, which is pretty good number. Only 4 patients lost follow-up, which is also a good number. So a great effort from all of the site investigators and teams. And the intention to treat analysis is the basis of this analysis. So this is the outcomes, and we measure the outcome in stroke based on the modified Rankin scale, which is functionality at 90 days and at 1 year. 0, 1, and 2, which is to the left side of this column, considered good, 0 being normal, 6 on the other extreme being dead, 5, you may think of somebody who needing 24/7 nursing assistant, nursing home, or bedridden. 4, somebody who is unable to walk, needing significant assistance with their daily living activities. 3, able to walk with a cane. 0, 1, and 2 being pretty much independent with some residual deficit. So these are large strokes. You're not going to see 60-70% of the patients having, functional independence and doing well as we wish they are, because at baseline they have severe disease. And the thought when I started talking about this, that they would not benefit, they will not do well with thrombectomy, there will be high risk. So this is the medical management. As expected, you have about 80% of the patients ending up with very severe disability, modified Rankin of 4, 5, and 6. And this is thrombectomy. And you see a shift, and that's how we measure the ordinal analysis, shift towards better outcomes with thrombectomy as compared to medical management. And that translated to 60% likelihood of superiority of patients being treated with thrombectomy to at least improve by 1 point on the modified Rankin scale as compared to medical management, and 1.5 the likelihood of achieving better outcome with thrombectomy, and the number needed to treat for that was 5. You treat, and this is a huge win, you treat 5 patients with large course strokes for 1 of them to improve. And you may say, well, I mean, you told me that patients are less likely to achieve a functional independence or walk independently, but what happened in these cases? Thrombectomy tripled the number of patients who achieved functional independence. Number needed treated was 7, and doubled the number of patients who were at least able to walk independently. This is the patient coming with a very severe stroke, plegic on one side, unable to talk, with a large stroke at baseline, and think of 100 cc's, half of their hemisphere being thought to be infarcted, that ends up walking independently at 90 days. Just to put things into context, this is a significant development that resulted in a lot of patients being treated and going back to their families and to the society independently. What about safety? The risk of symptomatic hemorrhage was actually pretty low. Just think, I mean, there was a lot of hemorrhages, but not symptomatic. Symptomatic hemorrhage, meaning worsening of the patients because of the hemorrhage. And we actually have only 2 patients in medical management who had symptomatic hemorrhage, one in thrombectomy. Mortality was reduced with thrombectomy, but did not reach statistical significance. So why there isn't a lot of symptomatic hemorrhages? Because these patients come at baseline with very large strokes. It takes a lot to make them worse, so to speak, and apparently we can make them better. The paper was published in the New England Journal of Medicine and presented simultaneously at the International Stroke Conference in February of 2023, I'm sorry. So we moved from there to what happened to these patients on the long term. Can they continue to improve? Can they go back when they go back to the family and to the society, and when the stroke sits with them? How do they do? Not just functionally. How do they do from a psychological standpoint, productivity standpoint? What did they and their family think at 1 year? So to our as expected, but to our happiness, so to speak, that the thrombectomy continued to do better. At 1 year, there were 20% of the patients that continued to have improvement, at least by 1 point. From 90 days to 1 year, the number need to treat was 6, and the outcomes were pretty much the same. This paper was published in The Lancet a year after and presented simultaneously at the International Stroke Conference. And I told you about the quality of life. What did they think? What did they and their family think? And that's pretty important, because you can keep somebody alive. You can say, well, I mean, they are able to walk, or some of them are, but did they think that that was in their best interest? And all of the quality measured, whether it's depression, whether it's cognition, whether it's other metrics in terms of functionality, all of them, whether either were less or more in favor of thrombectomy. So patients and their families said that, so their surrogates, that they would do this again if it were to happen, if they would have given the choice again. And then the third important concept here is, how large is large, and how can we define large? Is it infinite, or are there limits? I mean, there is no question, as the stroke sizes increase, patients are less likely to do as well as those who have smaller strokes. But that's the wrong way of thinking of things. And a lot of people say, well, he is not going to do as well as the patient who has 50 cc's or who has a smaller stroke. But that's not what you are measuring. You are measuring, are they going to do better than those who will not receive the procedure, better than those who will not receive the intervention? Of course, as disease is more severe, the likelihood of achieving the desired outcome would not be as well, but is it better than medical management? And that's what you want to know before offering the intervention, whether the family is interested in it or not. This is where prognostication come rather than selection and saying, I will not treat these patients. So we looked at all of those in different imaging modalities, and again, thrombectomy continued to be better than medical management without heterogeneity, even with patients with very large cores, more than 150 cc's. About a year later, there was a French trial that came and looked at the same concept with more than 150 cc's. They had a large number of patients, and thrombectomy was better than medical management. The likelihood of achieving the MRS of 0 to 2 and 0 to 3 decreased, which is again prognostication and discussion with the family, but it continued to be safe and better than medical management. This paper was published in JAMA at the same time that The 1-year outcomes were published at the International Stroke Conference and presented simultaneously. So another point that was covered in large part from the SELECT-2 trial. And then the other component that I mentioned to you that we have a large system at UH is what about where the patient present? What if they do not present to a thrombectomy center? They present, like most of the patients, they present where we do not have advanced procedures offered. I mean, we published a paper on this a few years ago. That only 1/3 of Americans have access to a thrombectomy center within 1 hour. So most of the patients will not present to a thrombectomy center. Do they still benefit from the procedure? Can we transfer them and proceed with the intervention for them to have a good outcome? And this is stratifying patients between those who presented directly and those who were transferred. And you see that the odds were in favor of thrombectomy with a shift towards better outcome. There's no question that the treatment effect was larger in those who presented directly, but was maintained in those who, and this is 1.5. I mean, this is significant, so to speak. And as you see, the reality is most of the patients present outside. So how do we work on that? We improve transfers protocol. We put advanced images in AI, which is exactly what we are doing here at UH. We're rolling out the same software that we used in the trial in all of our Northeast Ohio centers to identify these patients quickly and transfer them to offer them the procedure and have better outcomes, because time remains brain, and the longer the transfer took, the less likely the patients achieve the desired outcome. So there was no heterogeneity in the treatment effect when you looked at transfer versus direct, and this paper was published at the same conference in JAMA Neurology and presented simultaneously. These are the major sub-analyses we planned in advance that we will address every subcategory. We will address any concern that physicians or guidelines going to come up with. Years of planning is coming fruitful. There was a paper that looked exactly at the hemorrhage because physicians continue to fear the risk of hemorrhage. There is a paper that looked at anticoagulation and can you offer thrombectomy? And this is Dr. Pujara, my research team lead in Annals of Neurology, and showed safety in these patients. And there are other 6 papers that are accepted and will be published in the next few months. I will be here presented the cost effectiveness, which is a major component of, you are showing that a procedure is effective clinically, but how can you roll it into systems of care? Do the systems of care benefit from this? Is it cost effective? And I'll be presenting this at this conference, and we're looking at other things based on sex, based on hypodensity. So by the time of the next stroke conference, we will have exceeded 20 papers from the SELECT-2 trial. So what are the next frontiers? Do we stop here, or is there more to achieve? One of the major hurdles was the stroke size that I think we brought down pretty good with our colleagues from China and Japan, and we're in the process of pulling the data in Germany together to address every concept of the large core. The other major hurdle is time. You hear about patients presenting pretty late, beyond 24 hours. And this is an issue of disparities. Those who don't have access, those who are elderly, who live alone, and the stroke was not recognized early, minorities, they can present late. And a lot of times they don't even have the opportunity to be offered to transfer to a stroke center that can offer advanced treatments. It's too late. Why would I even make the phone call? So we looked at that in a like the same methodological approach that we have in the SELECT-2 trial. We started with SELECT with a non-randomized phase, and we moved to SELECT-2. Here we did a retrospective cohort, the non-randomized phase, if you may, with people across the globe, and published this about a year and a half ago. That showed safety and benefit, and a significant number of patients presenting actually beyond 24 hours. So we continue to have this problem, and we are, I think, in pretty good shape to start a randomized trial with federal funding that's going to be larger than the SELECT-2 trial that address this concept. And we are in the era of artificial intelligence, and we are in the while we want every single patient to be treated, we want every single patient to have the opportunity to be considered for thrombectomy. There is reality of identifying tissue that may alarm us to the risk of bleeding. One of my mentor and one of my colleagues, Dr. Bruce Campbell, in Melbourne, Australia, with his team, looked at the severity of the hypodensity and measuring it on the CT with the Hounsfield unit. And they identified a certain threshold that can identify patients who have higher risk of bleeding. This is one of the sub-analysis papers that will come, and we're working on an AI program that can, provide this hypodensity measurement to identify patients who may not benefit from the procedure and may not be transferred for the purpose of the procedure. And you see here in red the degree of the hypodensity as measured, and this is manual at this point. What we look for is to do it with an AI program, so it's available for everybody. Then the other point is what I mentioned to you, that 80% of the patients with medical management don't do well. While thrombectomy was better, it remains that about 60% of the patients don't do well. I would like for these numbers to improve. We have better understanding now of concept of imaging, understanding of treatment modifiers and prognosticators, and we can enhance the good outcomes that we are having by introducing ways of reducing the cerebral edema, neuroprotection, and reducing neurotoxicity to improve this number from 40% of the patients being walking independently to probably 60 or 70%. This is where adjunctive therapy, you are opening the blood vessel, you're improving the patients clearly as compared to medical management. How can you support this effective procedure to capitalize and optimize the patient's outcomes? This is earlier stages, so to speak, and this is where you need to work with pharma and identify the right agent. We work with a French company on a possibility, but unfortunately this didn't pan out in another trial with another intervention. So this is again translational research. It's another territory that you have to identify the right agent, the agent that can be delivered, and the agent that can improve the outcomes. We'll see how that goes. As I mentioned, this was in the heart of COVID. I might look as the face of this, but this was a great effort from people across the globe. I visited almost every single site. I didn't go as far as Australia. I'll do and select late. But really, people were greatly supportive, very, very, very helpful. And the last thing that I want to say is, you may think that this is a huge multi-million. It is multi-million dollars, but it's not as large as the usual. It's more pragmatic trial. You may think that there is a huge team behind this. It's actually me and my two people, Dr. Pujara, who I mentioned earlier, and Faris, who left us to go to residency, who did most of the work, of course, supported by the two institutions that I was at, but a lot of work from these two people to get where we are today. Thank you so much. Happy to answer any questions.
Very much, Dr. Siraj. We are going to respect your time difference, I think, and ask people to please email Dr. Siraj directly any questions you have. It is time for our coffee break. We have a fantastic lineup after the break. So maybe just grab a cup of coffee, a snack, and then head back in. We're going to start again in 7 minutes. Welcome back, everybody. A lot of excitement. Some great presentations this morning. All right. I'm really excited to introduce our next speaker, Dr. Yunmei Wang. Dr. Wang is an associate professor of medicine at Case. Her research has focused on the mechanisms linking immune responses to inflammatory and thrombotic diseases such as heart attack, stroke, and atherosclerosis. She'll be presenting today on leukocyte platelet interaction for treating inflammatory and thrombotic disorders. Dr. Wang.
Thank you, Dr. Tia. Thank you very much for the opportunity to share with you our exciting project over the last 20 plus years in 10 minutes. Yeah. So we have been working on inflammation and thrombosis. Those are, the inflammation and thrombosis coexist in many diseases. The evidence from our lab demonstrated that leukocyte platelet interactions plays a very important role in inflammatory disease such as thrombosis, demyelinating disease, etc. And I'm going to show you the evidence that proving that leukocyte MAC1 and platelet GP1B alpha driving the platelet leukocyte inflammation and target this interaction can mitigate the severity of a lot of diseases, such as I listed in the slides. So MAC1 belongs to leukocyte beta-2 integrin, and it has many ligands, including fibrinogen, ICAM, and GP1B alpha, and which we identified. I'm going to show you some data later. And it regulates innate immunity and regulates the adhesion, migration, and phagocytosis. The early work in the lab showed that targeting MAC1 reduces inflammation and restenosis after a wire injury and staining, which lead to the discovery of the GP1B alpha as a receptor for the MAC1. Through many peptides that corresponding to the Y-type MAC1 endomain, and the lab found that M2 peptide can block the interaction with GP1B alpha, but not blocking the interaction with fibrinogen. And through a series of mutagenesis work that involving the mutant cell line, and it further demonstrated that this M2 is responsible for binding to the GP1B alpha. Therefore, we developed an antibody against this sequence to target this interaction. And this antibody can block the interaction to binding to GP1B alpha, but not to other ligand. And importantly, the treatment of mice that after wire injury in a model of restenosis induced by wire injury showed that antibody reduced the inflammation and as well as the intimal formation compared to the control antibody significantly. And in the other model, we looked at this antibody also improved the kidney diseases, and which the data is consistent with the targeting genetically through the MAC1 And in another model, we looked at, our collaborator looked at, and the antibody reduced the macrophage binding to platelet. In addition, the treatment of the mouse, three doses treatment of the mice with the antibody significantly improved the clinical scores of the disease, which is consistent with genetic targeting the GP1B alpha. And in the thrombosis model, we looked at the effect in the large artery, that carotid artery thrombus is formed, induced by photochemical injury, and it showed the effect in prolonged the thrombus formation, and this is in agreement with genetic targeting through MAC1, and it also prolonged the thrombus formation, and we also looked at the effect at the small vessel microvasculature system, and it showed less thrombus formation. And so to further investigate the therapeutic potential of targeted in this interaction in vivo, we made mutant mice to disrupt MAC1 to GP1B alpha interaction. So before that, and this mice is made based on our finding that 2 amino acids are critical for the binding of MAC1 to GP1B alpha. A series of in vitro work showed that the mutation of 2 amino acids have decreased binding to the platelets or the proteins, but not to other ligands. So this mutant mice is protected from thrombosis, and in both large vessel, this is carotid artery, and also in the small vessel. And in addition, and this mice is protected from atherosclerosis formation development. And here we are showing you the model that the data from the accelerated atherosclerosis model, and it showed that the mutant mouse has less atherosclerosis formation, and we also have data in the traditional DLR knockout mice, which it's not here. And in addition to this data, our collaborator found that the mice is protected from radiation-induced inflammation. So is it safe to target MAC1? And to answer this question, we did a lot of tail bleeding experiment on the different conditions, used different method, and it all showed that both MAC1 knockout mice and mutant mice have normal bleeding times. In addition, and other assays showed that platelet adhesion or spreading are unaffected, and coagulation assays are normal. So this tells us that MAC1 is a safe target. So how about signaling? The engagement of MAC1, the engagement of MAC1 to GP1B alpha leads to bidirectional outside-in signaling, and it leads to the phosphorylation of the PKC, and also the downregulation of FOXP1, and as well as downregulation of upregulation of tissue factor, which lead to inflammatory response. On the platelet side, and the MAC1 GP1B alpha interaction lead to the phosphorylation of AK2. So what I showed you is briefly the evidence that we completed the discovery and the target selection steps. And we also completed the lead development and identification and the lead optimization and the validation steps, which I don't have time to show you the data. But in brief, we generated a large panel of anti-monoclonal antibodies, and we, through comprehensive screening strategies, we identified the top monoclonal antibodies with high affinity. We did the epitope mapping, and we confirmed the in vivo efficacy in a murine model of thrombosis and also a rat model of MI. And we humanized the antibody to optimize the antibody, and we also validated the efficacy of the humanized antibody in vivo. And with the support of the HDI, the Calida Therapeutics is continue the effort. So here is the funding source and the team behind this wonderful project. Thank you very much.
Dr. Wong, maybe you could stay for a couple of questions. Any questions for Dr. Wong? I'll kick it off. Oh yeah, go ahead.
Oh, thank you. I'm Faiz Safari from Neomed. Thank you for the presentation. You did talk about a mouse model knockout. Now, MAC1 expressed in macrophages and early osteoclast. Did you see any bone phenotype in those animals?
Bone phenotype, we did not look at that, but based on our so many work with different in vivo model, we did not notice.
Okay.
Yeah.
Thank you.
Thank you.
And can I just ask you really quickly, you showed that you inhibit thrombosis in both large and small artery models. Any concern about bleeding risk?
Yes, so, but our data showed that there's no effect on the bleeding risk. We did a lot of tests to show that.
Wonderful,
Yeah.
great. Any other questions? All right, thank you so much, Dr. Wong.
Okay.
Yes, sorry, Dr. Simon. Sorry.
Can you just tell us what happened in your rat model of myocardial infarction? It's a tell us about what you found. It's
Okay, so that is a rat model. The rat is salt sensitive. It is transgenic for human cholesterol ester transfer protein. With the transgenic, the rat developed atherosclerosis, coronary disease, and also the hyperlipidemia, and with decreased survival. But with our antibody treatment, just like every other day for 1 week, it's been a while, so I just trying to remember. Every other day for a week, that the antibody treatment prolonged the lifespan and also reduced the troponin level significantly. Yeah.
Thank you. Thank you very much.
All right. Okay. Thank you.
It's my great pleasure to introduce our second keynote speaker. Dr. Atul Chopra is an esteemed physician scientist with dual appointments at Case and UH. Dr. Chopra's groundbreaking research spans genetics, rare metabolic diseases, and novel hormone therapies, contributing significantly to precision medicine. With a background that bridges basic science and clinical care, his work has expanded our understanding of metabolic disorders and also opened new therapeutic avenues. Today, he'll share insights from his latest research, further highlighting the intersection of genetics and innovative treatments. Please join me in welcoming Dr. Atul Chopra.
Thank you for that very kind introduction. It's a real pleasure to be here. I think I presented at this conference several years ago. So I've got a few updates. Okay. I'm a medical geneticist. So our stories begin with humans. And really what I want to do is tell you a story today. The theme of the story is how you can go from one patient and make biological observations, just one patient, to start the whole journey off. And that's enough to open up a whole Pandora's box of discoveries. I won't talk about drug development today, just basic discovery. And really it's all about how do you discover new hormones. Okay, so several years ago, maybe like 12, I was still a resident at Texas Children's. I saw her in the clinic. And her name is Lizzie, and I'm not breaking HIPAA because this is all in the public domain. And the reason I saw her was for her extreme thinness, a BMI of about 10. You don't really see this all that often. Just looking at her phenotype, you can kind of tell you don't see this phenotype just walking around. It's very rare. And that's kind of all we knew about it. It had this weird, obscure kind of name, neonatal progeroid syndrome, which has since changed into Marfanoid progeroid lipodystrophy. Mouthful. It doesn't really matter. The reason I saw her is because of her extreme thinness. It was like, let's try and figure this out. That's why medical genetics is so great. This is not really a pitch for you guys to go into residency in medical genetics, although that would be great. But we solve mysteries, and it's fun. It's a ton of fun. You see a patient like this, and it opens up this whole thing about what's happening in there, right? Okay. Even in the rare disease world, patients tend to know each other, especially in the social media age. Lizzie knew Abby, who also happened to live in Texas. There's been maybe 10 patients discovered with this syndrome. So the fact that there were 2 in Texas and they were both willing to come to Texas Children's and see me was a minor miracle in and of itself. But they were looking for answers too. Okay, so Abby, BMI of 13. Let's just stick with the thinness. There's a bunch of other things happening that I won't get into. I want to tell a clear story. Okay, so thinness. When you see patients with thinness, in the clinic here, I direct a clinic specifically devoted to body weight. I see kids with extreme obesities, mostly. Extreme thinness, extreme obesities. The question remains the same. What does the energy balance equation look like? Because your body weight, all creatures on Earth, our body weights are determined by how much energy goes in and how much energy is lost every day. That's the energy balance equation. So in the context of extreme thinness, Lizzie, who has a BMI of about 10, eats about 955, say 1,000 kilocalories a day. That's about half to 2/3 of an age-matched, sex-matched control. Low caloric intake, okay? The second patient, unrelated to her, also eats about 2/3 of the calories of an age-matched, sex-matched control. All right, so now the story is heating up. This kind of doesn't happen by chance. And this is not a psychological disorder. They have been thin since birth. Okay? Big distinction there. So we're not looking at anorexia. This is not a psychological disorder. There was something else happening inside. The energy balance, when you look at numbers, they kind of tell you the truth. And what you're trying to get at is, where does the fault lie? Where's the problem? What's broken down? Is it energy intake, or is it too much energy expenditure? Both could conceivably cause thinness. Well, energy expenditure is also low. Both of these numbers, energy expenditure numbers, are low. So you have thinness, you have low caloric intake, low desire for food, and low energy expenditure. Well, low energy expenditure could never account for thinness. If anything, it should give you more body weight, right? Everyone with me so far? So the culprit here, very clearly, you don't really, not rocket science, you don't really have to know much more. The culprit here is low appetite, okay? Fact. Okay, 2 unrelated patients in the world with this weird form of extremely rare thinness that don't like food that much. They don't desire food as much as the rest of us do. The second thing to look at when you see a patient with extreme thinness, we call them lipodystrophies. I'm not going to use very big words today, but lipodystrophy is basically disordered fat. It's something you have to rule out. It's in the differential diagnosis. Okay? So it's like fat that doesn't develop well. When we see patients with bona fide lipodystrophies, what you find is diabetes, usually, insulin resistance, because fat is necessary for glucose to disappear into under the direction of insulin. All right? So when fat doesn't develop well, all that glucose stays outside and you get diabetes. These patients have the opposite. They have insulin sensitivity, low insulin, and that's enough to do the job. That's insulin sensitivity. Glucose is normal, insulin is low, all right? So this is a weird result to get for a patient with an extreme thinness. Again, this was telling us something. And both patients in the clinic, when I'm asking them questions about, hey, do you drink a lot of water? Do you pee a lot? These are diabetes-related questions. The answer to all of that from 2 unrelated patients was no, we don't have any of that. What we do have is we wake up in the morning and feel sweaty and feel a sense of impending pass out. and feel just not great. And all of that is alleviated by drinking some Gatorade or eating a chip or a cookie, high glycemic food. Okay, that's smacks both two unrelated patients. I keep referring to the fact that they're unrelated because two people telling you the same story, that it's happening by chance goes down, all right? So they have neuroleukopenia, less glucose, low insulin, a weird result, okay, for somebody with this kind of thinness. So what's going on? Not knowing anything about this disorder, and at Texas Children's, we had a huge medical genetics practice, 25 active clinical geneticists, all right? And of course, we did conference after clinics, and none of them had seen this disorder. None of them could offer any insight. What do we do in my practice when we don't know what's going on? We sequence them, right? So it's like throw the whole kitchen sink at them and see what comes back. Sequence the whole genome, the exome in this case. And what came back was also a very weird result. Mutations in two unrelated patients again, in FBN1, the Marfan syndrome gene, and both had the same character of mutation. They were truncating mutations at one extreme end of the gene. We call it the 3' end, all right? 5', 3'. On the right end of the gene, they were truncating mutations that were chopping the gene, all right? So whatever was produced would be chopped up, basically reduced in length. Okay, so already this is looking like, hey, this is real. This has to be real because the fact that they're two different patients, unrelated to each other, have the same phenotype, and have mutations in the same gene with the same character. This already doesn't happen by chance. But now FBN1 was on my radar. So now one can do a literature search. And out come 5 additional case reports of others around the globe making the same association. Okay, patients with extreme thinness with 3' truncating mutations in FBN1. Now it is definitely not by chance. 7 unrelated patients in the world, same thing, it's not by chance. I guess we have to use big words. In our language, we just have to use big words. This would be called a tight genotype-phenotype correlation. And it's sort of the gold standard that all geneticists live and die by. That's what you're trying to get to, a tight genotype-phenotype correlation. So you're looking at the right cause, molecular cause, for whatever you're finding on the surface. Okay, so what's happening? This is the protein product. It's called profibrillin of FBN1, okay? Profibrillin is cut normally in all of us, normal stuff. It's cut by a protease called furin at the C-terminal end, at one end, and that makes profibrillin into fibrillin. This big green protein is fibrillin. It's an extracellular matrix protein. It's huge. All right, it makes basement membrane. It makes structure of cells. It's an extracellular matrix protein, massive protein. Well, every cleavage event yields 2 proteins, right? So here's this little guy, only 140 amino acids. All this was already worked out by others who were studying Marfan syndrome, FBN1, fibrillin. This little guy is also released, but no one had ever studied the second protein before. They had studied fibrillin, they had studied this cleavage event as a means of trying to understand how profibrillin becomes fibrillin, very basic science, and how extracellular matrix forms. But nobody had ever found any cause to study this little protein before. What's happening in our patients? A bunch of gibberish, but really what this is here's our patients, here's my patients, and here's 5 other cases, right? And what we're looking at is the last 2 lines, the C-terminal most lines of the amino acid sequence, of the protein sequence. And what's happening is this little guy, this RGR, KRR motif is where the cleavage happens. The scissor comes along and cuts. Everything north of that is fibrillin, and everything south of that is the second protein. And the second protein is deleted in all the patients. It's gone. Remember, I said these are truncating mutations. Well, the effect of the truncation is the second protein is gone. It's just deleted. So from that emerged a very simple, again, not rocket science, a very simple hypothesis that turned out to be correct over time. The second protein is an independent functional entity, and its reduction in some mysterious way that we hadn't understood yet, we have understood now, causes this phenotype. All right? Everyone with me? Okay, how do you go about looking at that hypothesis? How do you go about examining the beauty of a hypothesis is now you can do experiments and actually test whether that statement, remember I made the statement here, whether this statement is correct. The first thing to do, if it's an independent functional entity, that it must actually survive. It must, after the cleavage, it's not just taken out by the body and gotten rid of. It actually lives, okay? So does it exist? And we found that it exists in the blood. So these are 6 basically unaffected control subjects, right? Control subjects, just you and I. And it's present in our blood at this 30-ish kilodalton size. If you use bacterial cells to make it, it runs at 16 kilodaltons, about half the size. And that's because bacteria can do post-translational modifications. They can add on a bunch of things to proteins. But in humans, it's present in our blood. And it lives at 30 kilodaltons, not very important. But it exists. That's the point of this. That's step number 1 in trying to prove this hypothesis. So we named the second protein asparagine. Funny story here. After we published our first paper, and we named this asparagine because patients have a white adipose tissue deficiency. I've just shown you patients with like an adipose tissue deficiency, fat deficiency, so white. And asparose is the Greek word for white, and asparagine is also highly expressed, FBN1 is highly expressed in adipose tissue, white adipose tissue, so asparagine, for better or for worse. So the first paper comes out in 2016, and I get a call from this reporter at the Times of London, okay? I'm sitting in my office at Baylor. And he's like, I'm a classicist, I'm a Greek classicist, and I can't find this word, asparose. And all diligence I'd done was Wikipedia, okay, what's white for, or the internet, what's white in Greek? And asparose came back. And a colleague, Nicholas Mitsiadis, who's Greek, I was like, hey, is this right? And he was like, yeah. And now this classicist, okay, is telling me that this word doesn't exist. He's never heard it. So for me, it was an oh crap moment. Like, these guys have named a protein after some gibberish word that doesn't actually exist. And it's in print by this time, all right? I can't take it back. And then he goes away and he comes back 30 minutes later. He calls me again 30 minutes later and is like, I found it. It's in modern Greek. It's like, I don't care if it's in modern Greek, as long as it's in some Greek out there. So that was an phew moment. Yeah, that was great. Okay, so asparagine. I'm going to refer to that second protein as asparagine from now on. Remember I mentioned the patients have this, they report at least, this feeling of hypoglycemia, right? That smacks of hypoglycemia. They also have lowish insulin levels to maintain glucose levels being normal, and I couldn't really fast them. They're very intolerant of a fast. They have to eat every 15, 20 minutes a high glycemic index food to keep from feeling bad, that feeling of hypoglycemia. And so I couldn't really fast them very well overnight. And really, I think that's why we missed the hypoglycemia in the clinic to begin with, but we did catch the lowish insulin. Insulin is a good readout for glucose. If your glucose is low, insulin will buffer and prevent. Glucose is essential, life-giving, okay? Neurons burn glucose constantly, and without glucose, we will seize and die, all right? So the body, and obviously we can't eat all the time. So the way the body combats that is when food isn't available, your liver makes glucose, but it's not making it at the level of like drinking sugar water. So insulin levels go down to keep glucose outside in the bloodstream so that neurons have constant access to glucose. So low insulin is actually a readout for lowish glucose, is how we've understood it over time. But really, what does asparagine do? I did a bajillion experiments, okay? But the ones these are the key ones from that first story. You do something called a glucose clamp or hyperinsulinemic euglycemic clamp, and that tells you the level of glucose production by the liver. Okay, it's the gold standard test. When you have too much asparagine, and we can do that in a couple different ways, the hepatic glucose production is elevated. And when you have too little asparagine, we can do that in a genetic way, being done here. I won't get into the details of that. You have too little hepatic glucose production. Pretty good. It was good enough to know that, this is real. When you throw glucose into the body of a mouse, if you just inject, asparagine into the body of a mouse, you just inject it, near instantaneous, you get a spike in glucose because the liver starts pumping it out. Okay, so that's the first function of asparagine. So we published this paper in 2016, and the title was Asparagine is a glucogenic protein hormone. But this story is just beginning. This was the discovery of asparagine and the first physiological task that it accomplishes. But hormones generally do many, many, many things. So the story actually continues from there. And of course, by this time, in the chronological order, we haven't actually solved the mystery of why the patients are so thin. The second story gets into that. Remember I mentioned that the patients are a loss of function model. They have too little asparagine. Think of the patients as they're a deficiency model of asparagine. When we put the same mutation in a mouse, the mouse has that exact same phenotype and has barely any asparagine that we can detect in its blood. Okay? And of course, we've deleted asparagine, right? This was a natural experiment. Nature deleted asparagine in these patients, and they have this phenotype of thinness. We found that asparagine is not only present in the blood, as I've just shown you, in that Western blot, it's also present in the CSF. And in the CSF and in the blood, which I'm not showing, it's fasting induced. So you have lack of food or you don't eat, asparagine levels go up in the CSF. So it's present in the blood. It's present in the brain. Not only is it present in the brain, plasma asparagine can cross the blood-brain barrier. Super important into some of the therapeutics that we are developing now, which I really won't get into unless you're curious. This is an IV injection in rats, an IV injection of asparagine. And an hour later, boatloads of asparagine have shown up in the CSF. And that only happens. This protein is too big to just diffuse across. It's about 30 kilodaltons. It's past the threshold for stuff that diffuses across. So this is some sort of active process, which we haven't really looked into anymore. But anyway, asparagine crosses the blood-brain barrier. And this gets to the crux of why the patients are so thin and have low desire for food, because asparagine does the opposite. When you don't have asparagine, you have low desire for food, low appetite. And when you give a mouse too much, an injection of asparagine, the mice eat like gangbusters. So they eat a lot more. 5 grams, 6 grams of food a day for a mouse is a lot of food. Okay? So we can basically control this process at will. You increase asparagine, food intake goes up, glucose goes up. You get rid of asparagine. You can do that genetically in humans, or nature does that genetically in humans. You can do that in mice. We've put the same mutation in a mouse. You can do that using monoclonal antibodies against asparagine. All the methods basically show the same thing. You get rid of asparagine or reduce its levels in the blood, you get a reduction in appetite, thinness, and reduction in glucose insulin levels. How does it stimulate appetite? It works on these neurons. Research is very reductive. So we only know what we know, and we don't know what we don't know, which sounds like a stupid, it just sounds like an obvious statement to make, but it's fairly profound for basic science. We don't know if this is the only way asparagine increases appetite, but it's one of the ways. Now, these neurons are pretty well known, AGRP neurons. They're in the hypothalamus, a nucleus called the arcuate nucleus, and they control appetite. So when these neurons fire, the mice become hungrier and go to the food and start eating. Okay, people had shown that many, many years, decades before we came along. We throw asparagine on these neurons, and they start firing. The resting membrane potential goes up, that's this red line, so they depolarize, in other words. And their firing frequency, it all bunches up, so they start firing more frequently. So that's one mechanism by which asparagine increases appetite. We've done a whole bunch of work on this. And this story we finished about 18 months after that first story. Asparagine is a centrally acting orexigenic hormone. Orexigenic is appetite stimulating. Okay. By this time, our lab had been recruited here, and I'll tell you a funny story about that at the end. What is the identity of the asparagine receptor? You have a hormone, it needs a receptor. No hormones work without a receptor. So a hormone is floating around in the blood and the CSF. It makes contact with cells. It can't talk to that cell and activate it without another protein that it needs to touch on the cell surface. That's a receptor. Okay? So we started looking for it in the liver and failed. For like 3 years or 4 years, we failed. It just didn't come up in the kind of experiment that I'm about to describe. So we were like, okay, let's do it in the brain. So we did this experiment in the brain, and it's a fairly simple, I think you'll find that research is, you increase things and you decrease things and you look for observation, like, hey, what happens? You look for correlates of that. In this case, it's also a very simple experiment. You take a bunch of mouse brain, you mash it up in 2 bowls. In one bowl, you throw asparagine, okay, on top of it, recombinant asparagine. The other one gets an irrelevant protein, GFP, not found in humans or mice, right? And you pull this asparagine with antibodies, and you ask the question, what else comes along? And then you ask that question using a technique called mass spectrometry. So fairly simple in concept. You pull it and ask what other proteins come along with it. All right? So we did this experiment 3 times and found 58 proteins that came with asparagine each of those 3 experiments. We actually did it 4 times. 4th time failed. But this was good enough. Out of the 58, there was just one receptor. And it was a big surprise that it was this receptor, which I'd never heard of before. It's called protein tyrosine phosphatase receptor delta. Another mouthful, but it's a phosphatase. It's an enzymatic receptor. So it has this stuff hanging out outside the cell, just flapping in the wind. That's where asparagine binds. And then it has a single transmembrane domain. So that's where it crosses the membrane. And then an enzyme, actually 2 enzymes inside, okay? And they're both phosphatases. They take phosphate groups off its substrate, whatever the substrate may be. So, okay, we'd never heard of this guy before. So at this point, you start looking for patterns. And I'll show you the data, of course. But the pattern that you're looking for is, if you get rid of this guy, do you get the same disease as the lack of asparagine? Do you get the same phenotype as lack of asparagine? So again, not rocket science. Super simple sort of level of thinking, just very linear. Somebody else had already done this experiment. Okay, this is our data. But way back, a Japanese group like 30 years ago had made this knockout mouse for this protein, right? I was 5 years old. And what they found was these mice did not like to eat very much, had a bunch of other things, but did not like to eat very much and weighed less. They were thin. So we got the mice from Japan, and we found that all that was correct. The mice weigh a lot less, and they also don't like food. Not as much as wild-type mice that have this protein. So mice without PTPRD, asparagine receptor, that came up when we pulled asparagine and asked what else comes along with it from neurons, mice without PTPRD look and behave like mice without asparagine. So this was important. Okay, this level of correlation was really important. If these mice didn't have this phenotype, we'd kind of know something is off with the story. A negative experiment doesn't tell you all that much. There are other ways in which this could be right and still not show the phenotype, but you do have to get lucky, okay? So luck is a very important component of making discoveries, and this was getting lucky in a big way. Number 1, we found it in an unbiased way. And number 2, the mice without it look and behave like mice without asparagine. So we kind of knew this was looking promising, that we are on the right track here. But the upshot experiment, the really important experiment is, when you get rid of this guy, do mice still respond to asparagine? Everyone can see why that would be the clear experiment to prove that this thing is necessary for asparagine to work. Everyone with me so far? Right? So we got rid of it, and we gave the mice too much asparagine. And I won't get into how we're doing it, but these mice now, the ones where plus is this receptor is still there. Okay, both alleles of it, both copies of it are still there. So this is still plus here, it's just cut off. So these are wild type mice on this side, okay? On this side are PTPRD knockout mice. In both cases, we're giving one group of mice too much asparagine. And in wild-type mice, of course, we already kind of knew this, that when you give them too much asparagine, they eat more. So this is food intake. That does not happen in knockout mice. I'm just showing you one snapshot. We've done this experiment a bunch of different ways. So this was sort of the critical experiment. Of course, we had a bunch of mechanism to do, and what are the substrates, and what does it take the phosphate group off of, and when PTPRD is not there, do AGRP neurons still respond to asparagine, all that. So the paper's chock full of data, right? I'm just showing you snapshots. And we published this in 2022. So protein tyrosine phosphatase receptor delta serves as the orexigenic asparagine receptor. A different group by this time had published what the receptor is in the liver, and it turns out it's a GPCR, unrelated to this enzymatic receptor. So this experiment that I just showed you, when you look at glucose levels instead of looking at food intake, the glucose levels go up even when PT-PRD is not there, telling us that PT-PRD is not essential for asparagine glucogenic effect that comes through the liver, but it is essential, completely crucial for asparagin's orexigenic effect, which happens in the brain. So that's why the title of the paper, it's the orexigenic asparagine receptor. The glucogenic one is different. And there's precedence out there for a hormone to use multiple receptor types. Okay, this also seemed a little weird, and I got a bunch of questions at conferences about it, but we found a few papers with showing that, different hormones like estrogen, insulin even, works with, different kinds of receptors. Bile acids, a different kind of hormone, works with a nuclear receptor and a GPCR. Hormones tend to do this. We do not understand the structural basis of this, but that's a question for tomorrow. Okay, orexigenic asparagine receptor. Now it opens up a whole bunch of opportunities. One thing you can do is ask the question, where is the asparagine receptor expressed? What tissues of the body have too much of it, have a lot of it? And the tissue that kind of stands out is the cerebellum, this stuff here, right? This is in humans, by the way, RNA-seq in humans. And the cerebellum has a whole bunch of the asparagine receptor. And of course, I've just told you that asparagine works in the hypothalamus. So the question became, what is the asparagine receptor doing in the cerebellum? And in the lab, we have a way of figuring this out. Before we get to that, asparagine is highly expressed in specific cerebellar cells called Purkinje cells. Okay, these are the largest neurons in the body, these triangular neurons. PCP2, so here's a red protein, a protein that's labeled with red color, and that shows where the Purkinje cells are and their morphology. So these are Purkinje cells and they're triangular. They're huge cells, huge massive neurons, and they're dendritic processes going into the molecular layer of the cerebellum. We don't have to know that. And green is PT-PRD, the asparagine receptor. And how we figure out whether a protein is present in that cell or not is through a type of study called colocalization. We look for the two of them overlapping, basically. So when you overlap green with red, you get yellow, and we get lots and lots of yellow. So this is pretty good proof, and we have other ways of showing it too, that PT-PRD is highly expressed in Purkinje cells. When you get rid of PT-PRD, you knock it out, red remains red. It doesn't become yellow. Okay, so that's... Now, Purkinje cells had been studied, might have been the first neuron in the body to be studied. I could be wrong about that, but they're big, so they're easier to study, and their function is balance and coordination. That's really the function of the cerebellum, balance and coordination. What is the asparagine receptor doing in a cell that controls balance and coordination? All right, so in the beginning, the hypothesis was it's controlling appetite, not only through the hypothalamus, but also through Purkinje cells. Just a hypothesis. Turns out that hypothesis is wrong, and I'll show you the data in a second. And how you go about answering that, and because all we knew was glucose and appetite. So naturally, we didn't have any other hypothesis. And we knew that the appetite was coming via the brain and the glucose was coming via the liver, so appetite. And it's not far-fetched. Two neuronal types, even far away, often work together. These dendritic processes, and axons are very long. So it wasn't far-fetched at all that Purkinje cells make contact with AGRP neurons, and the two neuron types work in concert with each other to coordinate appetite, to control appetite. I jumped ahead. So not only is asparagine present in the Purkinje cells, it activates them, same as it does AGRP neurons, which I showed you. But here's a different technique. Basically, this red stuff is Purkinje neuron activation, and you throw asparagine into the brain with an ICV injection, intracerebroventricular injection, with a spinal tap, right? And these neurons become active. When PT-PRD is not there, so that's this blue line here, you can't even see it. These neurons no longer respond to asparagine. So pretty good proof that this receptor, asparagine receptor, is necessary for asparagine-mediated activation of Purkinje cells. But what does it do there? And I already mentioned that, our first hypothesis was food intake. So when you measure food intake in those mice where the asparagine receptor has been deleted, specifically in Purkinje cells, there is no impact at all on food intake. And of course, we kind of knew that we'd find this because when the mice were born and they got older, there was no change in body weight, no difference in body weight. And I've just shown you two examples. You get rid of PTPRD from all cells in the body. I showed you that knockout mouse, remember? The one that was made in Japan. And those mice weigh less and eat less. But not the mice where you delete this receptor, same protein, only in Purkinje cells. But luckily, the way we were measuring food intake was using something called a Promethean metabolic chamber that also measures other things. So here's another piece of luck. We found that the mice drank less water. This wasn't part of our hypothesis. We had no idea whether thirst wasn't on our radar. Why would it be? But the fact that this machine was there and it was measuring a bunch of things, water intake and food intake, and we were using it just for food intake, we got lucky. We found that there was a reduction in water intake, even though there was no reduction at all in food intake or body weight. So this put thirst on our radar for the first time, okay? In contrast, when we remove the receptor just from AGRP neurons, the neurons in the hypothalamus that control food intake, you get a reduction in food intake and body weight, but no change in thirst, no change in water intake at all. So this is a very clear example of the same protein, same receptor, deleted in two different types of neurons, producing two completely different physiologies. And they do not overlap. One cell type in the hypothalamus, the food intake center, affects food intake. And in Purkinje cells, which are not associated with thirst in any way, shape, or form, except a couple human studies where 20-year-old studies, fMRI studies, where folks were made thirsty on purpose, and you looked at blood flow in the brain, the cerebellum kind of lit up like a Christmas tree. It's a correlative study, but telling those experimenters that, water intake, that might be something that the cerebellum also does. But nobody knew any more than that. There was this correlative human study, but that's it. This was the first example of you messing with the Purkinje cell in any way and getting a thirst phenotype, a clear thirst reduction. Okay, so this we published, basically came out in print like last month. And the title of this paper is The Cerebellum Modulates Thirst. Asprosin is not even in the title because no one knew that the cerebellum not only controls balance and coordination, it also controls thirst. Now this is fact, and it's out there. Surprisingly, when we measured balance and coordination from these mice that had knockout of the asprosin receptor from Purkinje cells, there was no change. And we measured it like 20 different ways. In all kinds of challenging tasks, there was no change in balance and coordination. So what that tells us is the same neurons can control two very divergent physiologies, balance and coordination and thirst, without any overlap. So this signaling mechanism, asprosin, its receptor, Purkinje cells, controls only thirst, has no impact whatsoever on balance and coordination. And however balance and coordination is regulated, doesn't appear to have any impact on thirst. Same neuron though. Okay, it's doing two very different things. Okay, and I mentioned that I'm telling you a story, right? So this story began way back, and I mentioned a discovery that just came out last month. Now it's a super exciting time in the lab because ever since we discovered PTPRD, the asprosin receptor, we know all the places in the brain that it exists. And we can systematically knock it out and ask the question, what else does asprosin do? That wasn't available to me from information that the patients gave me, and is not just readily visible on the mouse surface or the human surface. Does that make sense? So now we're on the verge of major new functions of asprosin and its receptor, and it's involved in a bunch of central things in the brain. So memory, anxiety, pain. We're developing therapeutics for all these. But asprosin is a very strange hormone. I got a ton of flack after that first paper came out, okay? And the flack basically came from the fact that it's created from a large structural protein. And folks who studied that large structural protein, their main question to me, full of skepticism about our paper and data, was, hey, how does this make any sense? How can a hormone, and hormones are generally pulsatile, they go up and down, they do their job, and then they disappear, okay? And asprosin is fairly pulsatile too. It's circadian in nature. Goes up with fasting, goes down when you eat. It does all that. What sense does it make for a hormone that's controlled like that, like all other hormones, to be attached and come from a large protein that is fairly stable in the body. It's a structural protein. I've taken the tack of like answering that question with like, I don't know, and it's not my job. Nature created the system, and what the heck do I know? Like why it created the system. But it is real because we found all this, and we published a bunch of papers on it, and every which way in which we test, asparagine does various things. And of course, the only way it gets created in the body is by getting cleaved off of fibrillin, okay? But still, let's consider this question and consider the fact that it's a strange hormone to be doing this. So viewed through the lens of classical endocrinology or classical extracellular matrix biology, this makes no sense, or very little sense. Hormones are generally not created this way, except that they are. So asparagine is not alone. So when you start thinking this way, you're like, okay, I'm going to comb the literature, and Bijou, who's my MD PhD student, is the one that did this. Like, what else is made like asparagine from a large structural protein? So here's asparagine from fibrillin-1. After our paper, a different group discovered placensin. It's highly expressed in the placenta, not adipose tissue, so placensin, which comes from fibrillin-2. It's also a glucogenic hormone, okay? Phil Shearer's group at UT Southwest, Albert Einstein, back in the day, discovered endotrophin, which comes from collagen-6, another large structural protein. And Judah Folkman discovered that endostatin comes from collagen-18. All right, so this is not weird. I mean, it is weird, but nature is doing it. And there are more examples than one. And nothing happens in nature just one time. So the fact that there are other examples is something to be expected. If you're right, and all the data points towards it, this is the normal result. Okay, where's all this going? So we published this. And so once we recognize this pattern, we're like, okay, we need to tell others about this pattern. Nobody has recognized this pattern yet. And no better way of recognizing a pattern than giving it a name. So we call these hormones that are made from large structural proteins. I'll read a little bit of this abstract. Cautamins, cauda meaning tail. So members of this class are derived from a cleavage event that also generates a much larger functionally unrelated non-hormonal protein. All right, so that's the dogma. We proposed this dogma. It is undoubtedly real because it's already happening, right? We have examples of it already happening. But the main thing it does is you can go fishing for more. So we started with one patient, and now we have 50 additional cautamins in the lab, approximately 50. They're present in you and I. Okay, they're present in all of us, in our blood. We've looked. We don't know what they do. It could be any function under the sun. Asparagine's functions we discovered because the patients without it, this experiment of nature happened. Couldn't do certain things. Regulate their glucose, regulate their appetite, regulate their body weight. We don't have that luxury now. So we've had to design a strategy. And I won't get into what that strategy is, but we have identified 2 brand new hormones with functions in the brain and the muscle. This could be literally, they could have functions, anything under the sun. And we will unveil them over the next 2 years, but this is working. And again, I'll tie it back to the fact that all this began with one patient. Unprecedented. Human genetics is an unprecedented Pandora's box of discovery potential. One patient. Generally, like clinical studies, lots of clinicians here. Clinical studies, you need thousands or hundreds, at least hundreds of patients to make sense of the signal, separate the signal from the noise. Not in human genetics. If you have an extreme example, one patient is enough. Okay, this is a real pitch for human genetics, for medical genetics. Okay, I have a lot of people to thank, obviously. Patients, the story began with, my graduate students, MSTP students, they've done all this work, postdoctoral fellows. Illa now has her own lab at the University of Kentucky. Our lab is a rotating sort of door. Lots of undergraduate students come through there. Couldn't have done all this neuroscience without collaborators. We don't know how to measure a neuronal activity in our lab. But we don't have to learn because there are others who know how to do it, and we make friends with them and ask them to do it for us. And then they publish papers together. Good way to make friends too. Roy Silito and Aaron's lab, they helped us with the cerebellum studies. We didn't know anything about the cerebellum. We didn't really know anything about thirst. Those guys helped us figure out that the mice had no problems with balance and coordination. They had all the fancy equipment that was necessary to measure it. Academic funding sources, University Hospitals, Harrington Discovery Institute. So I was recruited here in 2018 by Jonathan and Dan. And 2018, if you guys remember, was the year that LeBron was leaving Cleveland. So when the offer came through, I'm like, nah, I'm not going. I like to think that rational people would respond that way. But we had long conversations. Dan and Jonathan convinced me that, LeBron shouldn't be a part of my decision making. So we've been very happy here. It turned out to be a good decision, and we've been productive, and we couldn't have done it without UH and HDI support. Thank you.
Thank you so much, Dr. Chopra. Fantastic, fantastic talk. I actually have a book on my bookshelf that's only single patient studies. So starting, of course, with Banting and Best and going on from there. So I really appreciated that you highlighted that so much investigation starts with the patient in front of you. Questions? Yes. There's, oh.
Back there.
I'm pointing back there, but is there somebody over here who had the mic? Or okay.
Since you framed your talk in the form of a story, I was wondering if you could speak to any communication you've done back to the two individuals in Texas and how they've been either kept apprised or even helped from the research, even though it's still ongoing.
Right. So we've stayed in touch. Abby's story actually came out several years ago in the New York Times. The article is called The Thin Gene, and it's told from Abby's perspective. And both patients had been bullied on the basis of what they look like. And one of them, Lizzie, the reason I found her really is because she's a public figure as an anti-bullying advocate, right? You can see how that would make sense. After the first story came out, they both came over to Baylor, and we discussed the results and what it means. And for the first time, they had some inclination of why they didn't like food as much. Actually, they thought that they liked food a lot. And that's what you have to measure. You can't just take a patient's word for it. Because they were eating more frequently, the first thing was a misdirection. Like the first thing that came out of Lizzie's mouth was, I eat 8,000 calories in a day. We're like, this has got to be uncoupling. This has got to be too much energy expenditure because that's the only way you can explain this. Well, when they went into the metabolic chamber and Nancy Butte measured them, that was false. I talked to, they both have Marfan syndrome as well, and I didn't get into the genetics of how that happens. Fibrillin is messed up too. It's not just Asperger's, so it's a complex phenotype. So I often get calls when they end up in the hospital for various Marfan-related things, and then I coordinate their care in Texas. They both still live in Texas. I had a patient come from Utah, same disorder, a little kid, 11 years old. I can't offer them, so what would the treatment be in this case? At least for the Asperger's part, it would be giving them more Asperger's. Here's the reality of drug development. I cannot develop a drug for 10 patients in the world. Under no economic model does that work. Why do I talk about the economic model? Because that's the only way drugs get developed. It takes 30 million to even get to humans, do all your IND enabling studies and get to phase 1. And investors are not in it for the love and goodness. They're in it to make a return. I cannot raise money for a disease with 10 patients. In fact, my last company, Aseragen, we had a disease with, we were working on a disease with like 1,000 patients, and that was hard. 10 patients, forget it. It's not going to happen. So we can make Asperger's in the lab, and we can make it research grade, but there's no money. There's no way I can develop it into GMP grade, test it in a rodent model and a non-rodent model for safety, do a non-human primate study, file an IND, hire a regulatory expert to do that, get approved to do human studies, and then pay for a phase 1, phase 2, and a phase 3. Phase 2 even. Sometimes for orphan diseases like this, you can get by with just a phase 2. So that's the reality. I have not been able to develop a drug to help the patients directly. But Asperger's has taught us a whole bunch about, it's elevated in obesity, and we've developing it for that, and primary polydipsia we're thinking about because of this thirst, and a whole bunch of other drug development that's coming up based on the new things that we're learning, for which there appear to be many more patients. Does that answer your question?
Thank you for your storytelling also, especially for the non-MD population of us. We very much appreciate that. But I was wondering, we're all PMs in research here in this row, and I wondered how you prioritize now which of the codulins you're going to experiment with first, since you have a plethora now.
The short answer is we don't prioritize. I'm a big believer in the fact that the universe opens up and allows you to make some discoveries and doesn't open up and the door is closed for others. We will take what we can get, is the approach that we take in the lab. If manpower was unlimited, we would work on all 50 at the same time for high throughput. And I'd be telling you that, hey, we haven't just discovered 2, we have 10. I'd be very happy with 10. And I would care very little about missing the 40. And remember, this is an arbitrary kind of screen anyway. There was a threshold that was established. There are potentially many more than 50. We established some stringent thresholds, and 50 popped out from that. So I guess in my business, we will accept what the universe gives us and not worry so much about the ones that don't come up. But I can tell you this, because I think that's the motivation behind your question. How do you tell which one's important? They're all important. I think asparagine is a case study for how obscure things are important. If it's in the body and has been kept around for thousands of years because of evolution, it's important. And we figure it out. There'll be other diseases too. I could give you other examples of the 2 that we're working with. There are diseases that are already apparent from the 2 that we seem to have discovered. Right? They're all important.
Great, thank you so much. Really appreciate that that patient-centered talk. As part of our program, each year UHR&E hosts an abstract competition open to residents, fellows, medical and undergraduate students and postdocs. And this year we received over 60 applications after careful review and consideration. Here are our 11 winners, so congratulations to everybody. All the posters will be displayed in person today from noon to 12:30 here in the lobby, and I encourage you to take the time to review them. They're really varied and just fascinating. And for the abstract winners, we've prepared a prize for you. So please meet with the R&E team over here after the poster exhibit. We'd also like to thank our 21 abstract reviewers who volunteered their time and provided excellent comments. So thank you for supporting the program. And our next talk today will be the oral presentation of the highest scoring abstract from the competition. Kayla Klatt is a MD PhD student at Case Western Reserve University. She's in her first year of the PhD phase. She received her bachelor's in molecular and cellular biology from Johns Hopkins. She's conducting her thesis work in the lab of Reshmi Parameswaran, where her research is focused on uncovering the roles of serine proteases 1, 2, and 3 in immune cell-mediated toxicity. And today she will present her winning research project about CAR T cell therapy in scleroderma.
Thank you.
Thank you.
Thank you for that introduction. I'm very excited to have the opportunity to share the work that my lab has done to evaluate the efficacy of our novel BAF CAR T cell therapy in scleroderma. To begin with some clinical background, scleroderma is a rare autoimmune disease of the connective tissue characterized by excessive collagen deposition in the skin and internal organs. There are 2 main subtypes of scleroderma, limited and diffuse. Patients with limited disease experience skin hardening and tightening over the distal extremities and face, while patients with diffuse disease have skin manifestations over the entire body, as well as significant organ dysfunction. There are currently no curative therapies for scleroderma, but there are multiple B-cell depleting therapies currently being used in clinic that have been shown to be effective at slowing disease progression. Targeting B cells is an attractive strategy because B cells play a significant role in the pathogenesis of scleroderma. B cells have been shown to promote inflammation, endothelial dysfunction, and collagen production by dermal fibroblasts, while plasma B cells secrete autoantibodies. The survival of B cells in both normal and disease contexts is dependent on a signaling molecule called BAFF. BAFF, or B cell activating factor, is a cytokine that is essential for the development and survival of mature B cells. BAFF signals through 3 different receptors expressed on the surface of all mature B cells. These receptors are BAFF receptor, TACI, and BCMA. In patients with diffuse scleroderma, there is a correlation between serum BAFF levels and the modified Rodnan skin score and ESR. Both of these clinical measures are significantly higher in patients with elevated BAFF levels compared to patients with normal BAFF levels. Thus, elevated BAFF is generally associated with increased severity of skin sclerosis and inflammation. Here, we are proposing our BAFF CAR T cell therapy as an alternative B cell targeting option for the treatment of scleroderma. The BAFF CAR T cell is a 3rd-generation CAR T with 3 intracellular signaling domains and an extracellular BAFF ligand. The BAFF CAR construct is expressed in primary human T cells using the lentiviral transduction system, and we measure the efficiency of transduction by looking at % GFP expression correlated with exogenous expression of surface BAFF. We published in Nature Communications that BAFF CAR T cells deplete multiple B cell cancers. Shown here is one representative example where BAFF CAR T cell co-culture with the JACA1 mantle cell lymphoma line results in significant target cell killing. Our BAFF CAR T cells are currently in clinical trial for multiple myeloma at UH, and in the context of scleroderma, a major advantage of BAFF CAR T cells over current B cell targeting therapies is that BAFF CAR T cells can target long-lived plasma cells, which express the 3 BAFF receptors but do not express CD19 or CD20. To begin evaluating if BAFF CAR T cells can target scleroderma patient B cells, we used flow cytometry to look at expression of the 3 BAFF receptors on peripheral B cells from patient whole blood samples. Here we show a healthy donor control and 6 patients with scleroderma and demonstrate that the BAFF receptors are expressed on scleroderma patient peripheral B cells. Next, we wanted to assess directly if BAFF CAR T cells can deplete scleroderma patient B cells. Looking at the control, we see at baseline, 94 to 97% of patient peripheral B cells express the BAFF receptor. After co-culturing patient cells with untransduced T cells, we see modest depletion of the BAFF receptor positive B cell population to between 70 and 80%. After co-culture of patient cells with BAFF CAR T cells, we see significant depletion of BAFF receptor positive B cells, with 3 of these patients having complete depletion of this B cell population following co-culture in vitro. So in summary, what we've shown so far is scleroderma patient peripheral B cells express all 3 BAFF receptors and therefore can be targeted by BAFF CAR T cells. And we also show that BAFF CAR T cells deplete B cells from patients following co-culture in vitro. What we are interested in now is whether BAFF CAR T cell depletion of B cells results in delay or reversal of disease progression. To assess this, we are using a bleomycin-induced mouse model that develops skin and lung fibrosis. For this pilot study, we are administering treatments at day 7, which coincides with early disease onset. In future studies, we plan to administer treatments at later time points to assess the efficacy of BAFF CAR T cells at treating established disease. Lastly, I'd like to acknowledge all of my lab members and PI for their support of this project, as well as our collaborators, particularly the team at the Pathology Translational Research Core at UH for providing all of the patient samples used for the study. I'd like to acknowledge funding sources as well. Thank you for your attention, and happy to take any questions.
Questions? All right, I guess I get to start again. So what are the advantages, would you say, of your BAFF CAR T over the existing FDA-approved CAR Ts?
Sure. So there are currently 6 FDA-approved CAR T cells, 4 target CD19 and 2 target BCMA. Both of these approved therapies are single antigen targeting CAR T cells, whereas our CAR T cell targets 3 different antigens. So if antigen escape were to occur and target cells downregulate CD19 or BCMA, those CAR T cell therapies are no longer effective, where we've shown that our CAR T cells, they can target 3 antigens, and if 1 or even 2 of those antigens is downregulated, our CAR T cells are still effective.
And we always worry, the more targets we hit, the more side effects we could see. And any thoughts about side effect profile of BAF CAR T?
Yeah, so I guess in terms of targeting normal human tissues, we did some in vitro experiments where we co-culture BAF CAR T with different primary human cells from different tissues. We looked at airway epithelium, cardiac smooth muscle, hepatocytes, renal cells, and cells from reproductive tissues. And in vitro, there is no cytotoxicity of our CARs against those tissues. Another side effect that we must consider is B-cell aplasia, which occurs with other B-cell targeting CAR T-cell therapies. But because our CAR T-cell targets antigens on mature B-cells and will leave the immature B-cell population untouched, we think that that may be able to replenish the mature B-cell population.
Wonderful. Thank you so much, Kayla. We really expect to see a lot of greatness out of you. All right. This brings us to our final speaker today, Dr. Daniel Spratt. Dr. Spratt is the Vincent K. Smith Chair of the Department of Radiation Oncology and a tenured professor and chair of radiation oncology at Case. Dr. Spratt is an international expert in prostate cancer, clinical trial design, and biomarker development and validation. And today he's going to speak about genomic and AI-based biomarkers in prostate cancer.
So first, huge thanks everyone for being here today. I could spend all of this time thanking everybody that's been part of the research I'm going to show you. This is hundreds of people, probably over 40 grants, tens of millions of dollars that I am one very small part that I'm fortunate to present to you. So as I put this, and I like to start a lot of talks here when there are trainees, if there are any, as I say, even someone who's given thousands of talks, it's okay to get a little nervous. So everyone thinks none of the speakers are nervous, because when I was a trainee, I was like, how do people give all these talks? But anyways, hopefully this is an inspiration. So not just read the guidelines, create them. These are disclosures of various trials that I'm part of. So what the heck is the prostate? The prostate's a ping pong ball-sized gland that gets a lot of attention, sits near the bladder and the rectum. It is the most common cancer in men worldwide. Almost 300,000 men will get it in 2024. It's just about 1 in 7. It's still about 1 in 8, they round up, of men will get prostate cancer. So look around. Second leading cause of cancer death in men. It still kills more men every year than colorectal cancer, pancreatic cancer, liver tumors, brain tumors. So this is a real cancer. Fortunately, many men do very well with the therapies we have. Very unfortunately, it's the #1 cancer-associated cause of treatment disability, and this is because it has a long natural history. Unfortunately, there still is residual overtreatment of this disease, and the chronic treatment with chemical castration, which helps some of these men live for long periods of time, can be devastating. So how do we personalize treatment for this disease of these 300,000 men? Well, we do what's called risk stratification. So we use something created in the 1960s, we still use today, unfortunately, called Gleason grading by the famous Dr. Gleason. We use the PSA blood test, which really came into prime time in the 1990s. And then the extension of tumor, which thank goodness, this used to be by the rectal exam, now we do it by MRI. And when you combine these together in various ways, you create what's called the NCCN risk groups. This is basically our prognostic system that creates from very low risk all the way into metastatic disease. And the lower risk patients we now monitor. We actually don't treat. We don't treat their cancer, and that's the right thing to do. As you get into the intermediate and high risk, the backbone is either radiation therapy or surgery or both, but there's an increasing role of systemic therapy. And the systemic therapy in prostate cancer, the backbone is androgen deprivation therapy, or something that inhibits androgen receptor signaling. And so that testosterone, the main androgen in men, is made in the testicles as well as in the adrenal glands, and there's various drugs to inhibit this. As you see here, these all have effects, unfortunately, on the heart. The morbidity of ADT is non-trivial, okay? So, when we're reading and, textbooks and papers, it causes a variety of cardiovascular side effects directly and indirectly through metabolic syndrome, diabetes, high blood pressure, osteopenia. About 30% of men on long-term hormone therapy develop fractures, and lots of muscle loss. To patients, this is what they will say to each other. It made me fat, impotent, weak, I'm confused, I have no motivation, and I have bone loss. This is the #1 driver of quality of life decline in men predominantly with non-metastatic prostate cancer because they usually die of something else. So in a perfect world, right, we would have a beautiful biomarker and a perfect drug or therapy for every single man based on their exact phenotype. We do not have this. And when I was in training around 2012, 2011, we treated all men on the far left. They came in, we got their Gleason score PSA, and I treated every single guy the same. As I'll show you over this about decade journey, where we are now is quite different. Unfortunately, I showed you the many different ways we prognosticate patients, but sadly, when you look at randomized trial data, so there's over 10,000 men in clinical trials, and you look at how good are these tools, the Gleason score, these risk groups, and this is why I say I want Gleason score to go away, is that this is an AUC, this is a measure of discrimination, 0.5 is a coin flip, and they're all not much better than a coin flip. That's really scary that we're telling guys to do just radiation all the way to multiple years of radiation hormone therapy plus other drugs. So let's change this. So this all started with, I was a resident at the time. This is a retrospective, I would call this, I'll be careful with the words I use. This is an okay retrospective paper to be published. It's Mayo Clinic, who has this monstrous repository of data into the 1980s. We've identified about 400 patients that did not develop metastatic disease, a couple hundred who did. We did it, which for those currently doing gene expression data, we use something called a microarray, transcriptome microarray analysis, and 22 genes across 7 different relevant pathways, pretty accurately differentiated which patients would develop metastatic disease. This is where, and for those who review papers and grants, this is where probably 99.9999% of studies don't even get to this stage with clinical outcomes, but they don't go past this stage. This is useless. This is a nice paper. This is useless. This will never affect a patient's life if you stop here. So the next step is, okay, great, you did this in one study. We published in JCO in 2017. Let's look across numerous institutions, numerous studies, the VA. So we looked at Mayo Clinic, Thomas Jefferson, Johns Hopkins, the VA system, to show consistency, at least with these retrospective studies, that this may be something real. And then you look across black patients, white patients, different tumor stages, Gleason scores. Is this truly prognostic? Is this risk stratifying patients? Because if it's prognostic, it should work irrespective of all of these factors. A big problem with biomarker development is, right, all these clinical trials and the guidelines that are a result of it, you can't just say, wow, I've created this test. Now, this is how you should treat a patient. You have to somehow integrate that with the mass amount of evidence being constantly generated that's not using this biomarker. So we integrated this, we call it the clinical genomic risk groups, to take the NCCN risk groups, which define how we treat patients, and interlaced within it this genomic test. And effectively, what you see here is on the x-axis, this is the NCCN risk groups I told you, these prognostic groups, and the different bars are basically showing how it would be reclassified, given it's more accurate to use this genomic test. 2/3 of men would be treated differently and reclassified. So this, at least in clinic, lets you say, well, how should I treat a patient based on this biomarker score? And this is the biggest disservice to highlight this here. We then we validated this biomarker in 12 phase 3 randomized trials. That took years and years working with the NCI, with CTEP, with biorepositories in the US and internationally to show that across these disease settings, this consistently works, because you do not want to use a test or a drug in a patient that you're not very confident when you're going to change their management. And we updated this in 2022 across now over 40 studies we've done with 30,000 patients, that this is consistent kind of no matter how this is looked at. And then to make this something that others can look at, we work to partner what's called the GRID database. It's 150,000 patients that have had this genomic test with SEER, and you can link it. So now this is a variable, just like age and PSA is linked with SEER. It's not public yet. We get 2 years to publish away on it with SEER, but it will then be public for people to have hundreds of thousands of patients that you'll have their genomic information with real-world clinical outcome data. This led to 2 very large trials that I helped design through NRGs, over 5,000 patients in intermediate and high-risk prostate cancer, to personalize, based on this genomic test, the omission of hormone therapy or the intensification, so trying to reduce that over-treatment. But some men, like I said, still die of this disease. Everything I showed you previously with those randomized trials generates what's called Simon Level 1B evidence, which is very good. This generates level 1A evidence. So that's part of the story, and that's all cool academically, but I want my patients to have this test, right? And they're not going to spend $5,000 a pop on a test like this. And so in 2019, based on a lot of this work at the time presented, and I did not name this video, I don't know why it's called the Daniel Spratt video, but this is Palmetto GBA that I went to CMS, flew out there to present to them why they should be covering this test, and created a dossier with the company. And this now is clinically available, covered by almost every single payer. The average price per patient is $45, so it can be used. And next, in the hardest bar, which there's only a few of these in all of the guidelines, is our NCCN guidelines, which is what insurance companies basically dictate what they'll cover, as well as what our Bible of what we're going to recommend is. Now this 22 gene test is in the NCCN guidelines as the only level 1B recommended test. And next year, probably these other 2 you see here won't even be listed, because now that we have something that's level 1, why list something that has poorer evidence? It had direct treatment implications. This helps us guide the use of hormone therapy. It's something I order on pretty much every one of my patients now. So the question is, I fortunately was young when all this happened, and so can we do this again from the lessons over a 10, 15-year period to get to that? And we basically did and repeated it and accelerated it to just 3 years. And so everything I showed you is what's called a prognostic biomarker. Because prostate cancer can be indolent, if you can identify an indolent tumor, then why overtreat it? But if you have an aggressive tumor, it doesn't mean giving them hormone therapy will help them. That's a big misconception. So can we develop a predictive biomarker that, regardless of their prognosis, can intrinsically identify their benefit? And this is where they, skate to where the puck is going. And about 3 years ago, we said, well, what is all this AI buzz? I'm getting a couple little, feeds in my Google feed on this. Now it's everything. And we said, well, let's digitize all these tumors that we've been sequencing, and let's see if we can skip all that retrospective steps. Let's just jump straight in, get all the randomized trial data, train it on randomized trials, validate it, and see what we can come up with. And this would create the first ever predictive biomarker, which is what, again, I am just representing a monstrous consortium of work and AI scientists to do this. So we started with 5, now we have 10 digitized phase 3 trials. This is 4 randomized phase 3 trials, about 16 terabytes of imagery data. Just a single H&E slide is all that is needed. You don't need a tumor block. And we train this for the differential benefit of hormone therapy for these men. Critically important to validate a predictive biomarker is one of the hardest things you can do, because you need a randomized trial of the treatment of interest, plus or minus hormone therapy in this case, and identify what's called a biomarker treatment interaction. Are there some patients that benefit more than other patients? And to just jump to, The money shot here is this is distant metastasis, so the probability of developing distant mets. If you are what we call biomarker positive, based on this multimodal AI model, you have a hazard ratio of 0.34, a very substantial clinically meaningful benefit from adding hormone therapy. If you are biomarker negative, which importantly is 2/3 of men, all of these men we would normally give hormone therapy, but 2/3 of men would be biomarker negative and do not derive a significant benefit from hormone therapy. We went on, and there's more that is not yet prime time to show you, but we've validated this as a second predictive biomarker to see who doesn't need long-term hormones, 2 years of hormone therapy. On the left here, you can see with a different trained and validated model, we can identify men that do not need 2 years of hormone therapy and the side effects that I mentioned. You got to get it paid. It does no good for me to just present these at national meetings. You got to actually, because these tests, they want to charge $1,000 a pop. Now that CMS covers it, it's usually effectively almost free for patients. Because you get CMS approval, you generate level 1B evidence. It's now the first AI predictive biomarker or any AI biomarker in the entire NCCN guidelines. And it has direct treatment implications to how we manage patients and who we give hormone therapy to. So I say this as someone that started off not as the nerd I am today, that if I can do this, I promise you can do it too. But remember, it is very easy to create models, whether it's with MRIs, whether it's in cardiology, oncology. They have no value just creating a preclinical model or a retrospective model. They'll never be used clinically. The goal of cancer research at its core is to decrease the suffering of cancer. Some would say to eliminate cancer, but it's definitely to decrease the suffering of cancer, and don't forget this. Thus, the work you do should eventually reach the patient. So you have to keep going, don't give up, in order for this to actually reach the patient and them have access to it. Thank you very much for coming today. I really appreciate it.
Dr. Spratt. I'll go ahead and start off. Dan, I think what really struck me about your talk was there are thousands of biomarkers over decades that have been discovered. Why are so few of them actually incorporated into guidelines?
Yeah, so it's speaking probably more intelligently about prostate cancer is even, I listed here 3 tests, for example. And I'll go right here. These are what we consider these 3 tests. There's tens of thousands that will never reach the guidelines. These 2 bottom ones will probably be dropped from the guidelines because they simply did the retrospective studies, many of them, but never invested and took the risk to say, let's actually test this with real quality randomized trial data. One of them actually did, and it was negative, did not validate. So there's a risk to a company that they have to make that decision. Can I get some uptake in use and sales, or do I really want to become the Oncotype for breast cancer? I think in reality, as many people, they create something very cool. I mean, I've made tons of models that'll never be in guidelines, but you kind of know deep down that it's not good enough, or that it may not pass, muster to put this forward. You have to have a large body of work to convince, for example, CTEP to say, we're going to consume this unbelievably valuable tissue. So to get to that stage, right, we've probably had dozens of institutions where we retrospectively profiled to get as best data as we can. So it's, I think, persistence. I'm not saying people are lazy, but persistence to keep thinking of how do you get this to a patient. And often I feel like people create it because they've got, they're biostatisticians or AI scientists, and they think it's cool, and they do some really fancy work, but it's not good enough, or it's not clinically relevant to get to patients.
Yeah, that's a great question for you. In your 22 gene genomic classifier, or your subsequent one, have you identified any targets of interest? So can we move beyond androgen deprivation into actually targets of treatment?
It's a great question. So this is one of the big problems in prostate cancer, in the sense, because of that side effect profile, is prostate cancer has had one of the first targeted therapies. right? It is unlike where breast cancer will have ER positivity, prostate cancer is like 95% AR driven. So its target is the androgen receptor. You shut it down, the tumor, it stops proliferating. It works. So they have tons of different types of ways to inhibit. They now have AR degraders and all these things, but they have the same exact side effect profile. So the short answer is no. What we've learned through one of the really nice unexpected byproducts of this is we continued and encouraged the company that now bought Decipher called Veracyte to keep using a whole transcriptome microarray, not just the 22 genes by like PCR to make it cheap. And with that, we can now really understand the biology of prostate cancer in like 100,000 samples. And we have there's a molecular subtype of prostate cancer now that we're going to be putting forth that regardless of your PSA, your Gleason score, all this stuff, it doesn't seem to ever metastasize. It's good. And so we're going to be starting a trial that even in men right now, every man would get surgery or radiation. We cannot find a single part of this phenotype called luminal differentiated in any metastatic cohort. They don't metastasize. And if that's the case, then we should spare them, the side effects we cause.
One more question.
Yeah.
Is this on? Yeah.
And they're going to do this AI work actually in head, neck, and breast cancer as we speak.
Oh, that's great. My question is about AI.
Okay.
Great talk, Dan. So, you digitized all these slides. I assume this was a supervised learning module through AI, or and so it's self-supervised.
It's completely actually. So one of to Ted's point is, so there's different groups who will take a pathology slide and annotate all the human interpretable features. That's fine. I would say people are more comfortable doing that because it's what us as humans recognize. The limitation of that is you're only looking at things we recognize. And so by getting such a huge amount of data, we specifically wanted to skip the steps, so it's completely unsupervised. These slides, literally, there's no annotation at all.
So it's all generative then. It's all
correct. Exactly. So it's looking at. We're now trying to do explainability of what it's looking at, and I can tell you some of it's obvious, some of it no freaking clue what it's looking at. So it's a lot of work going into it. So Atala Beydoun, who's one of the physicians Ted helped me recruit here, he's an AI scientist, got his PhD here at Case Western, is doing explainability work on these models.
Great. I mean, that was the question I was going to ask. What are the features? But since it's generative, I think you're going to need to figure that out.
Yeah.
Great talk. Thanks.
What that brings up for me is, are we going to, sorry, Cliff, but not need pathologists anymore?
So I spoke actually at Cliff's annual retreat last year. I think that the short answer is yes, we'll need pathologists. Long answer is I view this as an unbelievably exciting time for pathology, that I guess we need to invest in pathology to get them high throughput scanners and all these things, because the models, and there's companies like there's this ARIA Matrix company. I've sat next to these private practice pathologists, and they have like 10 AI models. It instantly reads where's the cancer, the Gleason score, cribiform, etc. It's not 100% accurate, but imagine that resource for a pathologist would be very helpful, because there's millions of prostate biopsies every year, millions of negative ones, looking at 16 cores. I think this is an efficiency gain that we'll still need pathologists for. I don't know, Cliff, if you agree with that.
I'll just quote another chair of pathology around the country who a few years ago said, digital pathology is not going to replace pathologists, but pathologists who learn how to use digital pathology, and I would extrapolate to other tools that you're talking about here, the pathologists who learn to use those tools will replace those who do not.
Yeah.
Oh, very good. And on that note, I want to thank Dr. Spratt. I'd like to thank everybody for coming. And great job, Dan. I'd like to invite you all to the lobby to enjoy our really fabulous, diverse poster presentation.